Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome all the respected faculty and delegates for TNFOG Marathon CME on Healthy Women. So, with this, let me welcome our today's organizer, Dr. S. Sampath Kumari ma'am, who is a chief and HOD of Muthukumar Medical College and Research Institute, Chennai. And she is the Foxy Vice President elected in 2022. And she is the founder secretary, TNFOG. And she is the national correspondent editor for JOGI 2021 to 24. And she is a Senate member at Tamil Nadu Dr. MGR University 2021 to 24. And she is a chairperson for Foxy Adolescent Health Committee from 2016 to 18. And she is the deputy director at Professor OG Retired Institute of Obs and Gynec, Madras Medical College. And she is the president at Board of Studies, OG-TN Dr. MGR Medical University from 2015 to 19.
Thank you, Doctor. You can proceed.
Okay, come on. And she also received so many awards like Foxy Dr. Dirusha and Foxy Dr. N.A. Pandit Award. And she also written many chapters in Foxy textbooks. So with this, I hand over the session to Dr. Sampath Kumari ma'am to take the proceedings. Over to you, ma'am.
Yes. Thank you, Doctor. First of all, good evening to all, and I welcome you all, Dr. Sindhya Madam, Dr. Anjalakshmi Madam, Dr. Girish Mane, Dr. Lakshmi Madam for this and all other delegates for the wonderful International Women's Day CME. Our CME, today's CME topic is Healthy Women. As all of us know, this International Women's Day, how it is started in 1907, 15,000 women marched for the rights to vote. And then Clara from Copenhagen, she conducted a conference in 1911 for all working women. And she told that a special day should be created. So from 1911 only, this International Women's Day was celebrated. And since the Russia, similarly, in Russia, the women again, that day itself, they went for strike for vote for writing and equality and everything. That strike was started on March 8th. So we celebrated the Women's Day on March 8th. The tricolor of Women's Day is purple, green, and white. Purple for dignity, green for hope, and white for purity. With this, I hand over the mic to our convener, Dr. Rajeshri. She is an active EC member of our society, and she is a senior consultant in Cloud9 Hospital. Welcome, Dr. Rajeshri. You can take over.
Thank you, madam, for the kind introduction. And maybe now all have the Tamil Tal. We'll start off with the prayer. Tamil Tal Varthu.
திக்கணமும் அதிர்சிறந்த திராவிடனல் திருநாடும் கத்த சிறு திரை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் வணக்க இருந்த பெரும் தமிழனே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
We'll now have the lighting of lamp to dispel the darkness. The lamp of knowledge can be applied. Thank you. It's now my proud privilege to welcome Madam Anjalakshi Chandrasekhar. She is our beloved past President Proxy, Founder President TNFOG, Governing Council Member TIPSI. She's a PhD in Pregnancy Diabetology from Tamil Nadu Dr. MGR University. She's recipient of the Best Doctor Award from IMA. She's a retired professor of obstetrics and gynecology from Madras Medical College, and she's presented a number of papers in national and international conference. I don't think there will be anybody in this gathering who will not know her, ma'am. I request you to kindly deliver the welcome address, ma'am.
Okay, thank you, Rajashree, for this nice introduction. Good evening, everyone. Beloved chief guests, office bearers of the TNFOG, speakers, chairpersons, and my dear delegates. It is my warm duty to give the welcome address. Today we have the TNFOG Marathon CME for the month of March on healthy women to commemorate the International Women's Day celebration. Here, there are going to be discussions on various topics regarding the healthiness of women. For this program, we have a pleasant, smiling, cordial, and lucky personality, whatnot, a woman pro-activist, and she will always quote some suitable anecdote according to the situation. My good friend, always my well-wisher, Dr. Cynthia Alexander. Cynthia, I welcome you from the bottom of my heart, and with all my love and affection, and request you to bless the CME for its success, and also release a newsletter for the month of this March. And though everybody knows about Dr. Cynthia, for a formal introduction, can I have her CV? Rajashree?
Yes, ma'am. The CV. Yes.
She is the former director, IOG Chennai, Superintendent Government Hospital for Women and Children, former HOD, OB-GYN, Madras Medical College, Chennai, awarded A.L. Mudaliar Traveling Fellowship in 1988. She has got a Lifetime Achievement Award from Dr. Tamil Nadu MGR Medical University in 2011, Lifetime Achievement from DIPSI, Lucknow, 2017, Times of India and Economic Times Award, New Delhi, 2018. I welcome you, Cynthia. I also welcome our brilliant chairpersons, Dr. Annie, Dr. Chitra, Dr. Saroja, Dr. Kalpana, and Dr. Vairamani, and vibrant speakers who are going to talk about the healthiness in our women. Dr. Lakshmi Srikant, a very pleasant speaker, Dr. Girish Mane, Dr. Palaniappan, and Dr. Neharika Malhotra, and our beloved Dr. Shanti Gunasingh. And my dear delegates, I welcome every one of you to make this program a great success. I welcome once again. Thank you. Jai Hind.
Cynthia madam light போடுறீங்களா?
Mic போட்டுருக்கேனே.
இல்ல Cynthia madam கொஞ்சம் light போட்டா நல்லா இருக்கும்.
You are able to hear me?
Yes, ma'am.
Madam, இப்ப. Yes, madam.
So a lovely good evening to all gathered on screen. And thank you, Anjalakshi, very much for your words of introduction. I am really overwhelmed by this invitation, touched by this gesture of choosing me to be the chief guest. I thank my dear friends, Anjalakshi, Sampath, and Viji for the same, all brilliant women. So we have just concluded the International Women's Day celebration, and caring for our women, our organizers here have chosen a very apt subject, healthy women. A question which I'll put forward. Is women's health a choice or a chance? In some parts of our country and in some parts of the world, like Africa, Afghanistan, it is still by chance. 70% of our women do not have the means and the access for good health. I must pat myself that I belong to a state. Our state, Tamil Nadu, in that way, is doing excellently well. Tamil Nadu ranks third in the health index in India after Kerala and Punjab. So I'm very proud of that. Today, our stalwarts from all over the state are here to talk on the subject. I'm happy to see all of them bringing back memories of former days when they were my students, some of them, Shanti, Chitra, and some others. As we conclude this Women's Day celebration, we should recall, is it only a day of celebration or is it a day of introspection? How far have we come? How far have we to go to empower our women in health, safety, and education? I always say 4E is the letter E, 4E in capitals, should be practiced by everyone in society. Now, what are these 4 E's? First is empowerment. It is to empower our women, to give them the strength, the knowledge, the health, and a basis in society so that they have a voice of their own. In that way, I always think, looking back, the OG department, all the obstetricians and gynecologists are really empowered. Just imagine the long hours of duty that we have been allowed to do. We are sitting with our family, suddenly a call comes saying that head is on the perineum and we are rushing out. I'm sure our families really empowered us. So like that, we wish all our women could have that empowerment. Coming to equality, everybody in the family, society should have equality. I am a man, you are a woman, all that should change. And that will change when education is given to all. So as we educate our women, they will rise up to the occasion of having equality in society, at the workplace, wherever they go. And the last E, empathy. This should also be practiced in many families. Even this evening, as I made the tea for my grandchildren, I told my grandson, now it's your turn to clear the table. It's because I said, Akka is tired and she has come back from school. So that empathy must be taught to the younger generation and to the men of the house also. And the same way, empathy while traveling in schools, colleges, all everywhere. So these 4 E's should be practiced. Now, where do we begin to teach and practice gender equality? Now, this year, the motto was gender equality. So where do we start? I would first say the woman herself, the attitude of the woman to herself. At this time, I'm reminded of this story from the book of Genesis. God created Adam. And he looked at Adam and thought, oh, fine, my creation is very good. Then he thought, why not keep this as a rough copy and make a fair copy? And so he added some more color, long hair, a little shape here and there, and Eve was created. So actually, Eve is the better production of God. So we all must pat ourselves for this. So the woman must feel, must not feel, I am a woman, I am a second-rate citizen, have self-pity. So we must teach our women, be bold, be more empathetic, administrative, take care of yourself, take care of your health. Don't be a secondary-rate citizen like that. So the attitude of the woman herself must be emphasized to our women, whether it is our family members, our students, our patients, or our domestic servants, anybody, this should be emphasized. And the second point is the attitude of one woman to another. Now we hear so much of ill treatment in household matters, domestic violence, all this. So we should have this attitude of love and affection towards the other woman in our house, whether it's our daughter-in-law, mother-in-law, whoever comes, our domestic servants again, to our patients. So we must appreciate the other woman who comes in contact with us in our day-to-day life. So the attitude of one woman to the other. And thirdly, that is why this about the POCSO Act must be made known to everybody. If all women are aware of this POCSO Act, many women will rise up to the occasion of defending girls from atrocious activities. So this is also very important when the attitude of one woman to another. And of course, the third one, the attitude of a man towards the woman. I must now come to a point. Every time we had this webinar for the past 2 years, I always see Anjalakshi's husband behind the screen adjusting. I see Shanti's husband. I see Sampath Kumari's husband, Premalata's husband. And I'm really thinking, the attitude of the men in the house towards a woman. Great. It's really empowering the woman. So that is lovely. So if this message is spread to all the other homes, society will definitely be a better place, more safe, more lovable people in the society. And this year's FOGSI slogan, violence against women. I once read an article long back during the Nirbhaya case. The article was named Bare Branches. Now, what is this bare branches? It is recorded. Statistics shows that in some parts of India, there are schools, primary schools in small villages. And children go to these schools, say the boys especially. Sometimes the school is not run regularly. Teachers don't come properly. And these boys just roam around, go partly for a little class here and there. And then they come out as dropouts. Now, as they are these dropouts, so sometimes they roam around the village. And then afterwards, sometime later, these people are, the parents are not able to feed them. And they're not able to send them to a bigger institution in another place or a city for higher education. So these boys roam around, and after some time, they go to a city where they live under bridges or dilapidated houses, join together, cook something and eat. And for sake of pleasure and entertainment, they buy a cell phone, load up pornography, and they view these things. At that moment, a very pretty lady, very accomplished lady, she may be a top officer, a bank officer, coming that way. Now, these boys are in their adolescence. Now, what to do? Their hormones are also working. So this hormonal action overtakes their disciplinary action, and that is how some crimes are committed. Now, who is to blame? Is it the government or the parents or society? It is estimated by 2050, there will be 7 million boys like this roaming around India, posing a danger to society and to young women and girls. So where do we start? It is up to the government to see that education, at least skilled education, so that they can take up some skilled labor, so that these crimes are not. This is one way by which we can prevent violence against women. So I thought that point should be that important. And unless we educate our boys at home and in society, we cannot aim for a society which will honor women. So only then, in Tagore's words, we can say, where the mind is without fear and the head is held high, and where domestic walls will not be broken up into narrow domestic world will not be broken into narrow domestic walls, into that haven of freedom, let my country awake. So thank you very much, and Jai Hind. Thank you.
Thank you, madam. This is the reason when I thought of International Women's Day, I only of India, madam. ABC of women, no anger, beautiful smile, care for everyone. So you are an apt person for International Women's Day, madam.
Thank you, Cynthia.
Yes.
Thank
Madam,
you.
newsletter.
Thank you, ma'am.
Newsletter you have to release.
Our
Okay.
Anjalakshi madam is ABC of TNFOG. Anjalakshi Brave Chandrasekhar.
என்னையா என்ன என்ன
மேடம் எல்லாரும் TNFOG ஆரம்பிக்கிறதுக்கு யோசிச்சப்ப நீங்க தான் பிரேவா ஒத்துட்டீங்க. So Anjalakshi Brave Chandrasekhar. ABC
Okay.
of Women's India madam, ABC of TNFOG you.
ஓகே ஓகே
I'm just a backbencher. I'll just come like that.
Ah,
So it is with great pleasure that we have this opportunity of releasing the TNFOG e-newsletter. Great. And my congratulations to the office bearers for this enterprise of this letter which has been coming up. Great. My congrats and God bless.
தேங்க்யூ
கொஞ்சம் திருப்ப
தேங்க்யூ
fast
சிந்தியா
Madam, ஒரே நிமிஷம். சித்ரகலா, next page. This is special, madam. This TNFOG this month, we have Tamil article written by Dr. Nancy from
Nancy,
Hero.
right.
This newsletter contains 3 articles. One on adolescence, second on menopause, and this is on Garbhakala. What are all the tests we have to do? So, speciality of International Women's Day.
So great.
This is the DIPSI program. We had one adolescent program on International Women's Day. We had around 1,500 students participated in that. It was really wonderful, madam. These are all the programs done this month in TNFOG. Thank you, Chitrakala. Thank you, Cynthia, madam, for
Yes.
releasing the newsletter.
thank you so much, Cynthia ma'am.
Yeah.
Started off with a bang and also introduced the newsletter. You have set the ball rolling for the further programs in today's CME. Thank you so
Sure.
much, ma'am. Thank you.
Thank
Thank you. We'll now move on to the next session. And it's my privilege to welcome the chairpersons for the next session. Can I have the slide, please? Yes. It's with great pleasure that I invite Dr. Mary Annie. She's the president, Rotary Club District 3212-2021-2023. She's a past president, Nagarkoil Obstetric and Gynecological Society 2016-2018. She's a chairperson, South Zone Women Doctors Wing, Kids Club IME Tamil Nadu. She's a national coordinator of Safe Motherhood Committee, National IME 2021. Honorary faculty in obstetric and gynecology, Sri Mukambika Institute of Medical Science, Tamil Nadu, Dr. Somawell Memorial CSI Medical College, Trivandrum. She's the organizing chairperson, NOXCON 2016, 17, and 18. She's a judge for paper presentations and posters at many national conferences and invited faculty in many international and national conferences and webinars. She's a coordinator, Nursing Guild of India from 2017 till date. She has organized several awareness programs in schools and colleges, FOXY CME programs, walkathon, tree plantation programs, and medical camps. She's done 2 programs for the tribals in 2018 in Nagarkoil. She's a member of FOXY Committee, Adolescent, Endometriosis, Sexual Medicine, Clinical Research Committee, Public Awareness, Endocrinology, and Safe Motherhood Committee. She has several awards and laurels to her credit. To mention a few, she is received Appreciation Award 2021 from Rotary District 2021, IME National President's Appreciation Award for Women for Best Education Activity 2021, Appreciation Award of National IME 2021. Welcome, madam. Can I have the next? I welcome Dr. Chitra. She is currently Executive Director and Chief Consultant of Department of Obstetrics and Gynecology in SPS Hospital, Hosur since 2002. She was in Tamil Nadu Medical Services for more than 20 years and retired as civil surgeon. During her tenure in government service, she has achieved many laurels for outstanding service in family planning, lab sterilization camps, and obstetric care to people of Hosur. She's a founder president of Obstetric and Gynecological Society of Krishnagiri and Dharmapuri district, and she's the chairman, Women's Doctor Wing of IME Hosur. Welcome, Dr. Chitra. Can I have the next slide, please? I welcome Dr. Saroja Velusamy. She underwent her post-graduation and undergraduation from Madurai Medical College, and she served in the rural for 6 years, and following which she worked in Critical Headquarters Hospital for 15 years. She conducted several laparoscopic sterilization during her government service, and she's currently consultant of Karthik Nursing Home, and her passion is for non-descent vaginal hysterectomy. I welcome all the chairperson, and I request you to take over the session. Madam Dr. Mary Annie, can I ask you to introduce the first speaker, Dr. Lakshmi?
Thank you for the beautiful intro,
Thank
Dr.
you, ma'am.
Rajeshri. And good evening, everybody here. My senior. Good evening, everybody here, the seniors and my friends in Foxy. And special wishes to the TNFOG team, Dr. Anjalakshi ma'am, Dr. Sambat ma'am, and Dr. Cynthia ma'am, and all the senior doctors here. I'm very happy to introduce Dr. Lakshmi Shrikante here, who is well known to me and a very lively, bubbly person of Foxy, who's been doing a lot of academics here. And let me go to the intro now. She is chairperson-elect ICOG Indian College of OBG, National Corresponding Editor, Journal of OBG of India, Jogi, National Corresponding Secretary, Association of Medical Women India, Founder, Patron and President, ISOPAR Vidarbha Chapter 2010-21, Chairperson, IMS Education Committee 21 to 23, President, Association of Medical Women, Nagpur AMWN 21 to 24, Nagpur Ratan Award at hands of Union Minister Shri Nitin G. Gadkari, received Bharat Excellence Award for Women's Health, received Mehru Dara Hanzotia Best Committee Award for her work as Chairperson HIV AIDS Committee 2007 to 2009 in Foxy, Senior Vice President Foxy 2012, President Menopause Society Nagpur 2016 to 18, President Nagpur OBG Society 2005 to 2006, delivered 11 orations and 450 guest lectures, publications 30 national and 11 international, sensitized 2 lakh. Can I have the, 2 lakh boys and girls. I'm not able to see.
On adolescent health
Okay,
issues.
done on
Yeah.
adolescent
On
program.
adolescent health issues.
So much to behind you, ma'am, and very proud of you, and really very proud to introduce you here. And over to you, ma'am. And the topic for today is we need to save so much for the pregnant women and the entire women's society of our India. So now, madam will be talking about nourishment in pregnancy, and welcome you, ma'am, on behalf of TNFOG, and over to you, ma'am.
Thank you. Thank you so much, dear Mary, for your kind introduction. Very
Thank
good
you,
evening
ma'am.
to TNOG office bearers, dignitaries, and all my friends in the audience. Today, the topic given to me is nutrition in pregnancy. But nutrition per se is important for all the stages of our existence. But in this talk, I am focused on nutrition in pregnancy because we all know this new concept of fetal origins of adult diseases. That is why nutrition in pregnancy takes a very important part to update us on. Perinatal period is a brain time. This is a window of opportunity for nutritional optimization of brain development and future health and performance. So I'm talking about the diet in the preconception period, first trimester, second and third trimester, and during lactation. The 4 pillars of a healthy pregnancy diet is brain development, growth of the baby, immunity, and healthy digestion. So let us first see the role of micronutrients that affect the outcome in the offspring. If there is a micronutrient deficiency during pregnancy, the short-term consequences can be in the form of miscarriages, stillbirth, birth defects, small size for gestational age, and preterm birth. The long-term consequences can be the altered growth, body composition, compromised cardiometabolic, pulmonary and immune function, and poor neurodevelopment and cognition. So first, I would like to emphasize on the role of folic acid. So this is the diet which is rich in folic acid, which we all have to tell our pregnant ladies. They have to take leafy greens, asparagus, broccoli, papaya, but somewhere there is a myth that papaya should not be taken during pregnancy. Then Brussels, seeds, nuts, avocado, okra, cauliflower, beets, bell peppers, these are all very rich in folic acid. But is diet enough to give adequate folate during pregnancy? Natural folates are susceptible to oxidation and they rapidly lose their activity in food, and they are largely destroyed by cooking to the tune of 90%. Moreover, they have a low and incomplete bioavailability. Now ICMR has come out with recent recommendations for RDA in 2020 that is freely available on Google. Everyone can download that booklet and you all can see the recommended dietary allowance for Indians during pregnancy, the exact RDA recommendation. Now let us see why we should supplement these pregnant women. The role of pyridoxine along with folate in pregnancy is vital for the development of fetal nervous system and brain throughout each week of pregnancy. Pyridoxine also helps to alleviate nausea and vomiting, and it also helps to prevent the low birth weight. So these are natural sources of natural sources of vitamin B12. That is salmon, mushrooms, mutton, chicken, clams, milk and dairy products and eggs. The role of cyanocobalamin along with folate is also essential for the fetal neural tube formation, brain and spine development, and together with folate, it works to produce DNA synthesis and red blood cells. If there is deficiency of B vitamins, then it leads to hypomethylation of DNA, it leads to inhibition of DNA synthesis, and this in turn leads to hyperhomocystinemia. And why we are concerned about hyperhomocystinemia? Because if it is there, it can affect the fetal outcome and also it can have maternal complications. Fetal complications can be in the form of congenital abnormalities, more so neural tube defects and cleft palate. It can also lead to stillbirth, low birth weight, IUGR, and preterm birth. Maternal complications, it makes her prone for preeclampsia, preterm labor, placental abruption, gestational hypertension, and recurrent pregnancy loss. Not only in pregnancy, the folic acid, B12, and B6 we need throughout from preconception to lactation period, because in the preconception and first trimester, it is required for prevention of neural tube defects and congenital anomalies. In the second and third trimester also we need all these micronutrients for proper growth and development of the fetus, to reduce the hyperhomocystinemia, to reduce the complications associated with hyperhomocystinemia. It also prevents anemia, and during postpartum and lactation period, we need these micronutrients for the growth and development of the infant and also to prevent anemia in the mother and the breastfed child. In India, 41.6% pregnant women, they have folic acid deficiency. 65% of the mother, they have low plasma vitamin B12 concentrations, and 35% have elevated plasma total homocysteine concentrations. So let us know, we all know that folic acid is very important during preconception period in the first trimester. What about folic acid beyond first trimester? So this is the study where the author studied the effect of folic acid beyond the first trimester of pregnancy. And this is the first randomized trial to report that continued supplementation of folic acid during the second and third trimester reduces the plasma homocysteine concentration. This is another study where the author studied the cognitive performance of children at 3 years and 7 years of age when they supplemented the mother with folic acid beyond first trimester, and the authors concluded that children of folic acid treated mothers during late pregnancy, they had a higher score in the cognitive domain of developmental assessment at 3 years and in word reasoning testing at 7 years of age. Children from folic acid treated mothers also scored higher in verbal IQ, general language, and full scale IQ. So now you all have understood the importance of folic acid beyond first trimester. So don't stop your folic acid supplementation once the mother reaches to 14 weeks of gestation, but we have to continue it beyond pregnancy and during lactation period as well. Now let us come to the role of DHA in pregnancy and lactation. We all know it is very important for the brain and eye development. And the two families of essential fatty acids are omega-3 and omega-6. The primary sources which are present in the food are fish, fish oils, walnuts, in the seeds, flaxseed, linseed, chia seeds, and dark leafy vegetables are rich sources of omega. These are various studies which have shown the role of DHA intake during pregnancy. It enhances fetal and infant development and function. This is another study which has shown that in the last 3 months of pregnancy, there is rapid accumulation of DHA in the eyes and brain of the fetus, and the brain weight increases, making it increasingly important that the mother has an adequate DHA intake at this point of pregnancy. Plasma DHA levels in the mother, they were found to be lower in those women who suffered from preeclampsia as compared to the normotensive woman. Remember, very low levels of DHA is synthesized in the fetus and placenta. For the fetus, primary source is the maternal DHA circulation during pregnancy. So in the fetus, DHA plays a role in prefrontal cortex and for retinal cells development. And after the birth, it has a role in the learning and memory capacity and for the visual functions of the child. So remember, the period of dynamic structural neural growth occurs in the fetal brain during the 3rd trimester of pregnancy. Adequate consumption of omega-3 fatty acid is vital during pregnancy as they are critical building blocks of fetal brain and retina. DHA is the critical component of cell membranes in the brain and retina, which becomes available for placental transfer in the late pregnancy. Dietary sources of DHA are insufficient to fulfill the requirement in pregnancy. So the consensus guidelines have given recommendations that pregnant women should consume 200 milligram of DHA. And these are various bodies which have given this recommendation of daily intake of DHA during pregnancy. Now coming to calcium and vitamin D. The maternal serum 125-OH2D levels, they increase twofold during pregnancy, allowing the intestinal absorption of calcium also to get doubled. Most fetal skeletal growth takes place from mid-pregnancy with maximum calcium accretion during the 3rd trimester. Transfer to the fetus at a rate of 50 milligram per day at 20 weeks of gestation to a maximum of 330 milligram per day at 35 weeks of gestation is there. And the skeleton of a newborn baby contains approximately 20 to 30 gram of calcium. Poor pregnancy BMD and low calcium and vitamin D intake during pregnancy puts the woman at risk of preeclampsia, preterm labor, GDM, general ill health, and body aches throughout pregnancy and lactation. So these are the calcium-rich foods: milk, yogurt, soya beans, cheese, lady's finger, orange, almond, sesame seeds, and cinnamon. The common causes of calcium deficiency is, of course, low dietary intake, malabsorption, and concomitant vitamin D deficiency. The recommended calcium intake during pregnancy is 1.5 to 2 gram per day of elemental calcium in 3 divided doses, preferably taken at meal times from 20 weeks of gestation. Vitamin D is also very, very important during pregnancy. and the transplacental passage of maternal 25-OH vitamin D3 is the sole source of vitamin D for the developing fetus. If there is vitamin D deficiency, you can see that in preconception period, we all face the challenge of subfertility. First trimester, there is increased risk of bacterial vaginosis, then preeclampsia. Second trimester, increased risk of periodontal disease risk, gestational diabetes, and third trimester, preterm labor and cesarean section. Not only this, it affects the fetus as well. If there is a fetal hypovitaminosis, then this neonate might suffer from neonatal rickets, infantile rickets, tetany, and increased prevalence of respiratory tract infections and asthma. So these are the vitamin D rich foods: orange juice, egg yolk, mushrooms, cod liver oil, fatty fish. You can advise your patients. But despite having so much of sunlight, most of our population is deficient in vitamin D. And the various reasons for this vitamin D deficiency is, of course, poverty, illiteracy, more indoor activities, certain religions, repeated and unspaced pregnancies. Lack of vitamin D fortification program in the country is also one of the reasons. Increased pollution hampers the ultraviolet rays to adequately synthesize vitamin D, and increased skin pigmentation is also responsible for vitamin D deficiency. So this was all about the micronutrients and macronutrients. Now let us come to the role of protein in pregnancy. And what is the importance of protein? The expansion of blood volume and growth of the maternal tissues require substantial amounts of protein. Growth of the fetus and placenta also places protein demands on the pregnant woman. Thus, additional protein is essential for the maintenance of a successful pregnancy. Maternal protein restriction alone and in combination with energy restriction results in consistently decreased fetal growth. And what is more alarming is that the developing fetus may or may not adequately compensate for some of the effects of maternal protein deprivation, and this effect may even span generations. So we are really worried about the long-term consequences of malnutrition and protein deficiency. And the few amino acids which are very, very important during pregnancies are arginine, taurine, and leucine. If there is a maternal malnutrition, then it has a consequences for maternal health in the form of anemia, increased risk of infection, lethargy, weakness, and increased risk of maternal complications and mortality. But it also has the consequences for fetal health as well, in forms of increased risk of birth defects, cretinism, increased risk of IUGR, low birth weight at prematurity, increased risk of infection, and increased mortality and morbidity of fetus, neonate, and infants. This maternal nutrition influences the cell number and differentiation in the blastocyst. So it starts from the preconception period itself. The maternal nutrition restriction can lead to fewer cells in the inner cell mass of the blastocyst, and this can cause lower birth weight, restricted postnatal growth, altered organ body or weight ratio, fetal malnutrition, and origin of complex adult onset diseases. The general factors which leads to this malnutrition are general nutritional status prior to pregnancy, maternal age, maternal parity, cultural and psychosocial factors. If she is lactating and she has conceived again, weight gain during pregnancy, and certain metabolic or other complications of pregnancy. When we say that a pregnant woman has to have 11 to 14 kg of weight gain, it means that she has to have additional 200 to 300 calories per day. And this increases the average daily calorie intake from 2200 to 2400 to 2700 calories per day. These are very alarming facts as far as Indian statistics are concerned. 73% are protein deficient, 93% are unaware of ideal protein requirement, 84% vegetarian diets are protein deficient. 65% non-veg diets are also lacking adequate amount of protein. 97% pregnant women, they don't know their protein needs. 53% rated protein as most essential for its health benefits, but alarmingly, only 1/3 believe that lack of protein can cause weakness and fatigue. So there is much to be done as far as awareness about the importance of protein for overall health, and especially during pregnancy and lactation, we have to do a lot of work. These are the studies. This is evidence from meta-analysis that we have to provide pregnant women with balanced protein energy requirements. Balanced protein and energy requirement reduces the risk of stillbirth by 40% and the risk of SGA by 21%. Mean birth weight was increased by 41 grams. In this case control study, the author observed a statistically significant association of preterm birth with lesser maternal energy and protein intake, and maternal energy and protein intake also positively correlated with neonatal head circumference, chest circumference, birth weight, whole length, and foot length. So these are the various diet sources for protein which we can recommend to our pregnant women: the seeds, nuts, beans, grains, sprouts, eggs, dairy products, fish, lean meats, and soya-based milk and tofu. We all have to pay more attention to the type of protein in the diet than the amount of protein itself. These are various types of protein supplements which are available, that is casein protein, whey protein, soy protein, pea protein, and egg protein. These are the top fruits which are high in protein content. You can advise your patients to increase the intake of kiwi, banana, blackberry, apricot, passion fruit, raisins. So these can be taken by the pregnant female. During lactation also, the mother requires an additional intake of energy, at least 550 kilocalories more than her requirement for that particular age and weight. During the first 6 months of lactation and for the next 6 months, additional energy of 400 kilocalories per day has to be supplemented. Protein requirement is at its highest when lactation reaches its maximum, and the nursing mother needs about 20 to 30 grams per day of protein over and above her normal requirements. So this is the Poshan Abhiyan, which is by Government of India's flagship program to improve the nutritional outcome, and the aim of this Poshan Abhiyan is to reduce low birth weight by 2% per annum by improving nutrition in adolescents and pregnant mothers. So this is the booklet I was talking about. This is there freely available, and ICMR has updated, and this is in 2020 they have come up with the updated RDA requirements. Friends, this is my last slide, and this is telling you everyone about the ABCD of nutrition. A is activity, B balanced diet, C is calcium, D is dietary fiber, E is egg, F fatty foods, G is eat as much as you like, H is hygiene, I is iron, J is say no to junk foods, K is mainly focused on the prevention of kwashiorkor, L for legumes, M for milk and milk products, N is nuts, O is you have to control obesity, P for protein rich foods, Q is you have to quit your bad habits in the form of excess caffeine, alcohol intake, R is riboflavin, S is salt in moderation, T is prefer traditional foods, U is we all have to unite for health awareness, V is vitamins, W is drink plenty of water, X is for exercise regularly, Y is yoga, and Z is zinc for better immunity. So this ABCD is very, very important for all the pregnant women and the lactating mothers to have an optimum pregnancy outcome and to have a healthy child, not only during the neonate and infant phase, but also in the later part of that child's life. So thank you so much for your patient hearing. Thank you.
Fantastic, Lakshmi ma'am.
Mary, ma'am, you have to unmute. You're muted, ma'am. Yes.
Thank you, Lakshmi ma'am,
Thank
for
you,
the
Dr.
beautiful
Lakshmi.
presentation. As beautiful as you are,
Thank
and
you.
the alphabets of nutrition really was a catchy slide, I should say. You ended up very beautifully, and you stressed on the importance of folic acid in the second and third trimester, and the role of micro and macronutrients, and the protein deficiency, which we sometimes do not give much importance in our daily practice. So everything was so good, and then you really did it very well, ma'am. Thank you for the beautiful presentation. And let me thank the TNFOG team also for giving me this opportunity. And I take this opportunity to request all of you to vote for me for Chairperson Medical Education Committee FOXI elections. Thank you, one and all.
Thank you, Mary,
Thank you,
and best
Lakshmi
wishes.
and Arnab.
All the best, Mary.
Ma'am, please support me, ma'am.
Sure.
Thank you,
Thank you,
Mary
ma'am.
ma'am, and thank you, Dr. Lakshmi ma'am. Now, can we move on? I will request Dr. Chitra to introduce the next speaker.
Rajeshri chat box la edhum question unda Lakshmi madam.
Illa ma'am, illa.
Okay, thank you.
Good afternoon, everybody. It was a very nice topic on nutrition.
Start பண்ணிட்டாங்களா?
Ma'am, am I audible?
Yes, Chitra, you are audible.
Yes, ma'am. Ma'am, it was a very, very nice topic on nutrition, and particularly the ABCD slide was something very new and fantastic. Thanks a lot, Lakshmi ma'am. Now, I would like to introduce our next speaker, Dr. Girish Mane. Dr. Girish Mane, Chairperson, Adolescent Health Committee, FOXI 2019 to 21. He's a past president of Yavatmal OB-GYN Society. He's a past chairperson, Adolescent Gynec Committee 2018-20. Awarded Best Chairperson AMOGS 2018 to 20. Recipient of FOXI Smriti Mailan Save Baby Girl Runner-Up Award. Recipient of Best Society Award, AMOGS Award 2016 to 17. Recipient of Dr. Drusha Youth Trophy and Sri Sadhana Desai Award 2017. First winner of FOXI Talent Singing Contest. That's wonderful, sir. Contributed 5 chapters in FOXI Focus. Presented many papers in national and state conferences. Editor of FOXI Focus, Adolescent Intervention for Future Reproductive Health. Editor of AMOGS Focus, Adolescent Health, and editor of FOXI FAQ, Adolescent Health. You're most welcome, sir, and we are very happy to have you with us.
Thank you very much, Chitra madam. Thank you very much for a very nice introduction. And at the outset, I would like to extend my sincere thanks to Dr. Sampath Kumari, who is the only mentor in FOXI for me, and especially I joined Adolescent Health Committee only because of Sampath Kumari madam. Thank you very much, madam. And I extend my warm welcome and my regards to Dr. Anjalakshi madam and Dr. Vijaya Lakshmi, Dr. Cynthia, all the speakers, all the chairperson, and all the delegates. Let me share my screen. Is it visible, ma'am? Chitra
Yes,
ma'am?
Girish, visible. Girish,
Yeah,
it is
sure.
visible.
Yes, ma'am. Okay.
You can
okay.
go to slideshow.
But it is
Yeah, I have
not-
started, madam.
No,
sir,
no,
it is
but
not- it is not seen, sir. Can you please stop?
Just a
and
moment.
share
Just
again?
a moment.
Yes, sir. Yes, sir.
Can you see now?
Again, not in the slideshow mode, sir.
Okay. Actually, I have started my slideshow.
Yes, sir. Sir, while sharing the screen, please don't click any icons, sir. Just green color share and blue color share. That's it, sir. Don't click the PPT.
Okay, okay,
dialogue
okay.
box.
Sure, sure.
Yes, sir.
Just a moment. Is it visible now?
It's start. Yes, sir.
Yes,
Perfect,
yes,
sir.
yes.
Thank you, sir.
Yes, visible.
Okay, so once again, yeah, thank you very much, Sampath Kumari madam, and good evening, everyone. Today, after listening a very interesting talk on the nutrients in the pregnancy, we are going towards a very different topic. It is nothing but save the hygiene in the menses. And today I'm going to talk on the hygiene of a lady and hygiene of the nature. Yeah. Friends, access to the safe, non-shameful, non-stressful and dignified menstruation is not only the fundamental need, but it is a right of every woman and every girl. And as it is and need of every woman and girl, even it is a responsibility over the every woman and a girl to take care of the mother nature. And we should have a proper hygiene care, especially the menstrual hygiene care, with the no harms to the mother nature. Mother nature is selflessly providing all our needs. Now it is a time from our side to start to care for the her. Phrase the scenario in India, especially the knowledge of the menstruation and the menstrual management. It is very horrible, especially in the adolescents. Almost 6% girls, they have never heard about the sanitary napkins, and almost 100% of the girls, they never have discussion on the process of menstruation before their menarche. And there are various criteria on which the methods of the menstrual hygiene management they are chosen. It depends upon the culture and the context. Then again, it depends upon some health factor, then the financial factors, then how it is used and what cares we have to take, then the method of the disposal. There are, it depends upon what the beliefs and practices are there locally. Then it depends upon the local level of the knowledge about the menstruation. Again, it depends upon the materials which currently they are used and they are available and preferred in some particular locality. Sometimes it is considered whether they are wet or the dry. Then again, the factor of health is very important. It is always considered that whether this material is associated with the health risk. Then in particular areas or in the particular areas, the average age of the menarche is different. So again, the average age of the menarche is considered while choosing the material for the menstrual hygiene management. Then again, it is also the point whether it is going to damage the hymen or it is going to injure the hymen. These issues are again taken into consideration. Then the financial and the economy is very important. Many times it is seen that whether the single use cost or what is the single use cost of that material, then what is the long-term cost of that material, and many times the supportive supply. For example, if some girl is using the sanitary napkins or the washable, reusable pads, then the supportive supply, for example, the soap or the availability of the privacy and all these factors, they are also considered. Then it is also important to know whether the woman or the girl, she is familiar with the material, and how frequently that material needs to be changed and how that material is cleaned. These are the important points to be considered. Then availability of the private space is very important for washing, for drying, and for changing that material. They are also important. And the most important, how much that material is, how better that material is in absorbing, in drying and preserving, because these are very important criteria. Then many times the frequency of the disposal is taken into consideration. Then what are the local beliefs about the method of disposal? So these are all the criteria on which the material for the menstrual hygiene management depends upon. So these are the menstrual hygiene materials usually used in our country, in India. They are the menstrual clothes, then the reusable pads, menstrual panties, then commercial sanitary pads, the tampons, the reusable tampons, then the menstrual cup, the bamboo fiber pad, banana fiber pads, and water hygiene pads. So out of these three, the three materials which I have quoted in the red color, they are non-biodegradable, and rest all are the biodegradable. So let's consider one by one. Friends, everybody is well known about the menstrual clothes, because a few years ago the menstrual cloth was the main or sustainable sanitary option for everyone. It is definitely a sustainable sanitary option, but it needs to be washed properly, dried and sterilized by the sunlight, by the natural way. And one have to store it very in a dry and a clean place for reuse in the next month. So the advantages are they are cost effective because they are very easily available, and they are eco-friendly because they are biodegradable. But there are some disadvantages For example, they are very prone for the infections, and that's why they can cause vaginal discharge, the skin irritations, and urogenital infections. The recommendations for the menstrual cloth are everybody should use the new clothes rather than the used clothes, and at least one cloth should be used for maximum 3 months. Now coming to the reusable pad, they are almost same, but they are reusable because they are specially designed by the natural or the synthetic material for the menstrual hygiene care. They have, I mean, there are little evidences of the health impact of this reusable pads, and that's why they are better than the menstrual clothes. Then they can be used for approximately 1 year, and that's why they produces little less solid waste, and that's why they are causing the or they are producing the little menstrual waste. And the initial investment may be little bit higher, but if we calculate the annual cost, then it is definitely lesser. There are some disadvantages. For example, they are prone for the infection in the form of urinary tract infection, the skin irritations, and other infections. And in some rural areas, availability can be a problem. The menstrual or the period panties are especially designed for the challenged girls or the old ladies, where the changing of the pads or other material is little bit difficult. Everybody is well aware of the commercial sanitary pads. They are easily available everywhere, not only in the medical shops, but in the regular shops, then online, everywhere. The cotton used in their making is usually not 100% natural, but many times they contain the gels, the pesticides, and different kinds of chemical. It is of different sizes and different absorption capacities. Then they may contain the blends of plastics, rayon, and cotton. There are definitely advantages. For example, the adverse health effects are not reported. They are very, user friendly, and the skin compatibility is a little bit better than other methods, but they are having huge disadvantages. They need to be disposed of after maximum use of, maximum 8 hours. They are expensive as compared to the cloth pads or other, materials. Then they are not reusable, and that's why they are not eco-friendly as compared to the other materials. And friends, one woman creates 150 kg of non-biodegradable waste in a year. It is very important to know for every lady. Then almost 1 crore pads are used in only 1 month in our country. Then one pad takes almost 100 years for its complete decomposition or degradation. India produces almost 113,000 tons of waste in the form of sanitary in a year. And as these pads are disposed after one use, they create a large quantities of the liters, and they accumulates in the landfills. They blocks the sanitation system, they contaminates the rivers, they cause various health issues in these sanitary workers, and even because of contamination of the river, even they are able to spread the diseases also. Then disposal of the used pad in the flush toilets can clog the pipes, and they can cause health damages into the building. They release toxin when they are burned incorrectly, which can be injurious to the health. Then coming to the tampons, they are the absorbent materials made up of the cotton and or rayon, which are inserted into the vagina. They are having one string for the proper use. Then they come in the variety, different sizes and different materials. They may not be without the applicators for the assistance or for the insertion. Then they can be worn up to the 8 hours. Nowadays, these sponge tampons, which are biodegradable, they are also in the market. The advantages are the sponge tampons, they are biodegradable, and they are a little bit comfortable, especially in the married or in the non-virgin ladies. But they are again having a lot of disadvantages, just like the sanitary pads. They are not user-friendly, especially the virgins or the females in rural areas. They may not be comfortable for using these tampons. Then they are definitely expensive even than these sanitary napkins. Then they may be, they can be associated with the severe toxic shock syndrome if they are not changed, or they are not changed at the proper time. Also, the urinary tract infections and the vaginal infections, they are more common with the tampons as compared to the all other methods. Then they are not accepted by most of the population, especially in our country. Then the residual chemical and the fragrance, they can lead to the allergic reactions. And as tampons are disposed after one time wear, they are causing heavy or huge litter because they are not biodegradable. And flushing of this tampon in the toilets again causes the clogging of the pipe and severe damage to the maintenance, and they can cause health issues with the sanitary workers. Now coming to the reusable tampons, they are washable tampons made up of the natural material like bamboo or wool or cotton or hemp. They are knitted using the natural absorbent material like cotton or the wool. They are inserted into the vagina to absorb the menstrual flow, same as the disposal tampon. The advantages are it is biodegradable, and that's why they are nature friendly and they cause less health issues. Again, disadvantages, they are not user friendly, because most of the females in India as well as the virgin girls, they definitely they will refuse such kind of methods. Then they are expensive as compared to all other methods. Then they can cause toxic shock syndrome if not taken care properly, and they are not available everywhere. Now coming to the bestest menstrual hygiene management in India, which is available right now, which is menstrual cup. They are non-absorbent, shaped silicone. It's almost 3 times more blur than the pads or the tampons, and they need to be emptied after every 6 to 12 hours depending upon the flow of that girl or that lady, after which they are just need to be rinsed and should be reinserted without any other formality. And after each menstrual cycle, the cup must be boiled for 5 to 10 minutes and can be preserved in simple cloth. And most manufacturers, they offer at least 2 sizes, and there are different kinds of shape, and they are reusable up to 5 to 10 years depending upon the care and the maintenance taken by that girl or by that lady. And the cost ranges between 350 to 2,500 depending upon the company and the material. There are very small disadvantages with this menstrual cup. Number one, there are some cultural barrier for use, because these are the newer methods and most of the females, they are not comfortable. They may not be aware of such availability of such kind of instruments. Then they are less acceptable and advisable in the unmarried and especially in the virgin girl. So this is the menstrual cup. This is the structure. They are having one stem which helps to locate the menstrual cup, and there are some air holes for the easy removal, and there are some markings which indicates the capacity of that menstrual cup. Friends, there are lots of advantages of the menstrual cup. Number one, they are very easy and pleasurable to use, but initially most of the females, they feel little bit uncomfortable, but एक बार सोच लिया पहनना तो बिल्कुल ही problem नहीं है. So they have to very considerate, have to use the menstrual cup for the sake of the nature, and once they start using it, it is the most pleasurable menstrual hygiene management. Then they are easily available everywhere. They are reusable almost for 5 to 10 years. Then it is probably the cheapest method of menstrual hygiene management, even cheaper than the menstrual cloth. Then it works for the longer time, and that's why less frequency of changing, because depending upon the menstrual flow, at least one lady needs to change the or reuse that menstrual cup, or needs to rinse that cup after 8 to 12 hours. As compared to the changing of these pads or tampons after 8 hours. Then cup can be used at least for 5 to 10 hours, and that's why they produce very less menstrual waste as compared to all other methods, and that's why they are eco-friendly. They are not injuring the environment at all. Then the disposal is very less expensive. There is no harm from the toxins or the fumes to any person who is doing the disposal of these cups. Then there are very less health issues with to the users with this menstrual cup. Then there are no damages to the sanitation or the drainage, and that's why there are no health issues with the sanitation workers. Then no feeling of shame for the disposal, which is there with the sanitary pads or the other methods. Then the cups are often perceived as better than pads or the clothes in relation to ease of washing, drying and storing, because the methods of washing, drying and storing for the reusable pads and the menstrual clothes, they are a little bit difficult as compared to the menstrual cups. Then they are comfortable, they are the leakage protection, the odor development and quality and length of the wear, they are better than as compared to all other methods. So these are the steps of menstrual cup use. First, the lady should wash their hand with the soap, and remember, use a menstrual cup only when you are menstruating, not before and not later on. Then one should not wash that menstrual cup with the soap. It should always be sterilized with the boiling water. So these are the methods of using it, either by C-fold, 7-fold or the punch down fold. And the cup should be lubricated using the warm water, and no other lubricant should be used before the insertion. So these are the better positions for insertion, at least, either squatting or one leg on the commode. Then insertion of the cup can be done in this method. It should be inserted, it should be pushed, and it should be ensured that it is properly opened. And after pushing or after putting that menstrual cup, the lady should stay calm and relaxed after insertion. And everybody should remember that menstrual cup will not cause a pain or cause any discomfort after when it is inside, because many ladies, they are they are fearing for the pain or discomfort after using that cup. Now these are the things to be done for the removal of the cup. First thing, one should locate the stem, then reach to the tip of the cup and pull gently. Then measure the blood loss. Nobody should pull that stem for removal of that cup. Then empty the blood, then fold and reinsert again and ensure that it is opened. And very important thing, one should not sterilize the cup at the time of reinsertion. The sterilization should be done only before the first insertion. And there is no need to remove the cup when the lady goes to the washroom for any purpose. There are two methods. There are two sizes of this menstrual cup, small and large, depending upon the need. Then 3 mantras should be remembered for the acceptance of the menstrual cup. Number 1, mental preparedness for the use. Number 2, at least for 3 cycles, the lady should be very patient and try only at the time of the menstrual cycle and not during non-menstruating time. So friends, it's the time to make your periods trash free, rash free, and crash free. Next is the bamboo fiber pad. They are the biodegradable pads. The advantages are they are affordable, then they are easily decomposed, and that's why they are environment friendly. Also, the bamboo charcoal pads are available in the market with the advantage that the blood stains are not clearly visible and are also reusable in the nature. But the disadvantage is that they are not easily available everywhere, and there are some issues with the hygiene. Then is the banana fiber pad, the same thing. They are biodegradable, and again they are not found everywhere. Then the last one is the water hyacinth pad. Again, this is the biodegradable. Friends, if we summarize all the factors or all the parameters and we compare all the parameters for all the menstrual hygiene materials, and if we ask a question, are you experiencing the happy and the healthy period, then this is the comparison. After using or after comparing all the parameters with the sanitary cloth pad, then disposal pads, tampons, everything, you can say the menstrual cup is the bestest in every capacity. I mean, it will give the freedom from odor or the rashes. Then they have better capacity, they are environmental friendly, they are most economical. Then patient can sleep throughout the night. She will never need to get up for changing the pad which is there with the pad. Then you are free to do any kind of physical activity because the thing is what inside the vagina, and there is no shame for the disposal, and there are so many advantages using the menstrual cup. So it is our duty to advocate or to spread the message of using the menstrual cup everywhere in your patients. So this is a small comparison between the menstrual cup, reusable pads, sanitary pads, menstrual cup, and tampon. These are the points. Friends, there are some facts regarding the menstrual waste disposable techniques in India. Appropriate disposal of the used menstrual waste is still lacking in most of the parts of our country. Most of the countries, they have developed a lot of techniques for the management of the fecal and the urinary waste, but nobody is taking care of for the disposal of the menstrual waste. Most of the females, they are disposing sanitary or tampons with the domestic solid waste, and toilet facilities in India, they are lacking for the disposal of the sanitary pads. Actually, the problems of flushing the used menstrual material in the toilets, it is more in the urban areas as compared to the rural areas, because the rural areas, there is a availability of the lot of space for burning or throwing these pads into the pit latrines, and that's why the most of the issues with the sanitary napkins, they are seen in the urban areas. Even in the school, because of the lack of sanitary facilities, the girls, they are they are reported to have absence from the school, and they are bunking the school during their during their menstrual period. And the another causes for lacking the school by the adolescent girls, they are broken door of the toilet, then the lack of water tap, then the bucket or poor water supply. Means there are no, there are no facilities for changing the pads or disposal of the used pad, and that's why many girls, they are getting they are doing absence in the school. Then in the rural, it is seen that the behavior of the most of the women regarding, especially regarding the disposal of the used menstrual material, is different when they are in the home and when they are outside. Most of the females, whenever they are in the public places, they flush, either they will flush the used pads in the toilet, or they will wrap all this material into the polythene and they will throw in the dustbin, which they are not doing in their home. And that's why these things, they makes the toilet dirty. It becomes the breeding place for the flies and the mosquitoes, and definitely also unhygienic the other toilet users as well as the cleaners of the toilets. So what are the consequences of the menstrual waste disposal? As I have already told you that one sanitary napkin takes 100 years for its proper decomposition, and that's why it is definitely harmful for the mother nature. And again, in the urban area, especially the clogging of the drainage system, it causes issues in the building as well as the health issues to the people who are the cleaner of these systems. So these are the consequences of the menstrual waste disposal. That the deodorized sanitary napkin products contain the chemical used for the bleaching, such as organic chloride, which when buried into the soil, they can disturb the soil microflora, and the decomposition takes time, and that's why they can harm the fertility of the soil. Then the people who are living alongside the river, they throw the menstrual waste directly into the river, and that's why there is contamination of the river water. Then the sanitary pads soaked with the blood and soaked with the blood of the infected woman may contain the germs like hepatitis or HIV viruses, which remains in the soil for many months together, and they can be spread to the other people. Then incineration is a better technique to for the disposal of the menstrual waste, but burning of the pad directly releases the harmful gases like dioxin, which can be carcinogenic, cause damage to the environment also. So friends, everybody, there is need of planning for some strategies for the management of the menstrual waste, and not only the government, but it is the duty of the using these menstrual pads. It is the duty of the doctors to spread the knowledge about the proper disposal of these used pads, and the companies who are dealing with the manufacturing of the sanitary pad, they should they should mention the chemical decomposition, the chemical methods or the chemicals used in that pad on the wrappers, so that the proper disposal methods can be applied for the disposal of these pads. Then environment friendly chemicals should be used for the manufacture of the sanitary pads. Then the guidance regarding the menstrual management should be spread amongst the adolescent girl as well as the women, especially in the rural areas. Even the females in the urban areas, they are in need of proper guidance regarding the proper disposal. Then safe disposal of the used pad is the need of time, and everybody should be encouraged to use the incinerator instead of wrapping these pads and to be disposed of along with the other garbages. Then the toilets should be designed in a way that they should be woman friendly or the girls friendly, for especially for the disposal of the sanitary pads. Then there should be some separate collection system for the menstrual waste, and it should not be along with the other waste. Then the government should create some appropriate policies and the legal framework, which is very necessary for the management of the menstrual waste. Actually, the government has many laws regarding the disposal of the other things, but they have not come up with the legal framework for the disposal of the for the management of the menstrual waste still. Then the government as well as the non-government organizations should work, and they should prepare the user-friendly toilet systems, and especially the facilities for the disposal of the menstrual waste. Then there should be some scientific research on this issue also. Then allocation of the budget should be there, especially to the schools or the other places for to support the menstrual hygiene management. And the use of the incinerator should be, informed, or it should be done in a proper way, and everybody should dispose the used pads or the tampons with the help of the incinerators, and the proper quality of the incinerator should be provided at the public places. So these are the recommendations for the proper menstrual hygiene method. Menstrual cup should be encouraged for every woman, even to the girls wherever possible, because many girls, they are comfortable for using the menstrual cup, because the menstrual cup are even available in a smaller sizes, and many girls who are active, sexually active, then the use of the reusable cloth pad as compared to the sanitary napkin should be sprayed upon. Then the biodegradable products should be given priority as compared to the non-biodegradable products. Then the use of incinerator is very important. There are not only electrical incinerator, but the clay or the cemented incinerators are also available, in which there is no need of any electricity, and everybody should be aware of proper disposal techniques wherever we are spreading the knowledge of the use of sanitary napkins. So friends, to conclude my talk, these are the take-home messages for everyone, that every medical person should be aware of these facts. I mean, how much non-biodegradable waste we are creating every year, and how much time it is taking for one sanitary napkin to for the proper biodegradation. Every medical person should be aware of this, and we should educate the society about this knowledge, then start using and encourage to use the reusable pads and menstrual cup, because it is seen that most of the even medical, the medical females, all the females who are concerned with the medical health industry, they themselves are not using the menstrual cup. So jo bhi achhi cheez hoti hai, it should be started always from our home, and if you are using yourself, then it will be easy for you to encourage or to educate the other woman. Then avoid use of non-biodegradable material for the menstrual hygiene management. Then use of incineration, even if you are using this non-biodegradable material, should be encouraged. And it is my personal request to everyone, please start using either menstrual cup or this biodegradable pad yourself. Then it will be definitely easier, and will be easier for you to reach and to educate all other ladies. Thank you very much, Sampath Kumari madam, for this opportunity. Thank you very much for your patience here.
Fantastic.
Thank you, sir. It was an excellent talk, sir. And I think you have thrown a lot of light on the menstrual cup, its usages, and it's very, very informative, sir. Thank you so much. Sir, just a little question I would like to know.
Yes,
what about the dioxin-free pads now that are freely available, they say, in market?
Madam, actually, some companies, they are saying that they are producing some dioxin-free pads, but they are not, they are not available everywhere. And it is not, proven that these pads are they are not creating this dioxin. The first thing, use of incineration is very less in India, and that's why even if they are producing the dioxin-free pads, but unavailability of incinerators everywhere is the more important problem, rather than availability of these dioxin-free pads. Because even if I am having that dioxin-free pad, but if I am not having the incinerator, then it is not of any use,
And for household use, what is the best way to dispose, sir? So we cannot go for an incinerator in every household. So
ideally the pad should be wrapped in the newspaper rather than wrapping them in a polythene, and it should be handed over to the government this waste disposal methods, so that these things, they are incinerated in a proper way, instead of throwing all these things in a polythene or out of the home, or in a sanitation method. It is always better to wrap all this material in the newspaper, and it should be handed over to the government, these people who are collecting the other solid waste.
Wastage collecting. Okay. Yes, sir. I think that was a very informative and nice. Thank you so much.
Thank you, ma'am.
Thank you, sir. Thank you so much, Dr. Girish. It was an excellent, very informative talk. Thank you, Dr. Chitra, the chairperson. We will now move on to the next talk, and to introduce Dr. Shanti, I request Dr. Vijayalakshmi Gnanashekharan. She's a treasurer TN Fogg, executive committee member of OXY, and she's currently consultant at Chintamani Hospital and associate professor at ACS Medical College and Hospital. Viji ma'am, please take over. Hello.
Thank you so much, Rajshri. It's really a privilege to introduce our own Dr. Shanti Gunasingh Madam to our own audience here. Madam is a consultant in ONG. Presently, she is a former director, retired as former director and superintendent Institute of Obstetrics and Gynecology. She was also the former director and superintendent of ISO KGH and HOD of OBG department, Kilpauk Medical College. She has served as project director, Center of Excellence for Tubal Microsurgery in KMC. She is a past president of Women Doctors Association, executive committee member of Chennai Menopause Society, master trainer for BMonk, CMonk, tubal microsurgery, lactation management, recipient of A.L. Mudaliar Traveling Fellowship Award. She is invited speaker at various national and state level conferences, and she has participated in radio talks and television shows for creating awareness among women, and she has conducted numerous free medical camps. After her retirement, Madam has really taken up free medical camps and service as her sole motto instead of joining any other place again for work. So Madam, one main thing is, Madam, it was very a privilege to have Madam as the past president of OXY. That's the main identification for Madam, a very good academician. Over to you, Shanti Madam. Welcome you.
Thank you, Viji, for your extremely kind words. It's really a pleasure to have you as my
Viji, one point. At any time, if you ask Shanti Madam to deliver,
Yes.
immediately she will accept.
Say like, yes, yes,
Even
yes.
at the last minute. So thanks a lot. to Shanti.
Thank you, Madam. Yes, ma'am. Yes, ma'am.
Can you see my presentation?
Yes, ma'am.
The topic given to me is in the SAVE series, Save Menopause from Stress. So we know that menopause is a natural life event in women. Life expectancy of women has increased. So women spend nearly 1/3 of their lives being postmenopausal. This has resulted in more women being adversely affected by symptoms of menopause, often to the detriment of their families, work, and life in general. Many women suffer in silence. Emma Thompson said that the trick is to age honestly and gracefully and make it look great so that everyone looks forward to it. But what is the reality? So we see so many caricatures. There is the 7 stages of menopause: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho. See this poor Carol. She has found her own way of coping with the hot flushes. So how do we have a rocking menopause? So what exactly is the impact of menopause on women? It has both physical and psychological symptoms. Hot flashes and night sweats are commonly reported, can lead to profound sleep disturbances over many months, low mood, irritability, and poor concentration as a sequel to changing hormone levels and sleep disturbance, sexual dysfunction due to vaginal dryness causing dyspareunia and loss of libido. And now this period is really a turbulent period, midlife and beyond. So primary roles in relationships are changing. Parents are aging while children are grown up and do not require the same kind of assistance. And they may have to deal with illness, financial issues, career shifts, marital problems, divorce, death, and early stages of mental or physical decline. So essentially, it is a period of which has really become topsy-turvy. So what are the symptoms and signs of menopausal transition and beyond? We should know that menopausal transition occurs well ahead of menopause. So around 40 years itself, vasomotor symptoms, sleep disorders, and mood changes, which can be really very debilitating, start. Then menopause, of course, sets in. And before that, there can be troublesome menstrual disorders, And after that, there can be urogenital atrophy and dyspareunia, and later in life, osteoporosis, atherosclerosis, coronary artery disease, and cerebrovascular disease. So what is the Indian scenario? The mean age of menopause is 46 plus years, which is way ahead of the menopausal age in West. So this predisposes to chronic health disorders a decade earlier than Caucasians. Osteoporotic fractures occur 10 to 20 years earlier, and myocardial infarction and type 2 diabetes mellitus at younger age. We, as diabetic capital of the world, are seeing even adolescents having type 2 diabetes mellitus, and the burden of cardiovascular disease has increased by 110% since 1990. So menopause is indeed a phase of life which seem to require management. So coming to menopause and stress, many women find the time around menopause stressful. This may be partially due to hormonal changes and resulting bothersome symptoms, hot flashes and disrupted sleep. And as I told earlier, family and personal issues resulting in midlife crisis, and chronic stress adversely impacts the health. So that can result in hypertension, headache, gastric reflux, depression, anxiety, and heart disease. Chronic stress affects immune system, so there is an increased susceptibility to infection, illness, and even cancer. Stress affects relationships, work performance, general sense of well-being, and ultimately the quality of life is very much adversely affected. Neuropsychiatric symptoms like mood changes such as depression, anxiety, irritability, crying spells, cognitive decline, verbal and memory loss, and decreased ability to cope with mundane problems may present at menopause transition. These may be associated with declining estrogen levels, and hormone therapy may help. In a study conducted by our own Indian Menopausal Society, vasomotor symptoms were reported by 75.3% of women and psychological symptoms by 62%. Common causes of mood disturbances during menopause transition can be untreated vasomotor symptoms, recurrence of major depression, new episode of depression, nutritional deficiencies, hypothyroidism, medications for acute or chronic disease or other treatment, stressful life events, adjustment to age-related social changes, and even socio-economic status. So we come to anhedonia, which is the inability to enjoy, which is a core symptom of depression. So it's very, very important for us to keep ourselves joyful. Spectrum of depressive disorders ranges from a temporary phase of depressed mood to a clinical depression disorder. Depressed mood is a normal, brief period of feeling sad that is commonly experienced and rarely requires treatment. So this is dysphoria. So this can be a symptom, and it can be an adjustment reaction to all life events and medical or psychological problems. This is short term, does not require treatment, but it can progress to clinical depression. Depression that occurs most of the day, more days for at least 2 years, is dysthymia. It requires treatment, especially with a psychiatrist. Women with a history of clinical depression are susceptible to another depression at menopause. So it's very important to take a good history of previous depression. In menopausal transition with vasomotor symptoms and depression, hormone therapy probably helps. In new onset depressive mood at menopause transition, treatment response to hormone therapy may be re-evaluated after 3 months and other forms of therapy considered. Non-pharmacological methods for coping depression is an essential part of management. Deep breathing exercises, muscle relaxation technique, daily exercise, yoga with meditation, healthy diet, psychological support, social interaction, and creative outlets that enhance quality of life. Stress leads to disease and disease leads to stress. So prevention of disease saves menopause from stress. So this paper clearly states that healthy lifestyle during menopause transition is associated with less subclinical atherosclerosis. So midlife and beyond is a critical window for cardiovascular prevention in women. So we talk so much about exercise. So the mantra should be sit less and move more. So shake your legs. That is the most important thing. We know the innumerable benefits of exercise. It increases endorphin production. So this stabilizes thermoregulatory center and decreases hot flushes, improves self-esteem, maintains healthy weight, increases in metabolic rate, improves bone density, coordination, balance, muscle strength, joint mobility, improves lipid profile, reduces cardiovascular risk, reduces genitourinary problems, relieves depression. That is the most important thing that we have to note. Induces sleep, improves quality of life, reduces levels of body stress hormones, adrenaline and cortisol. It stimulates the production of endorphins, which are body's natural painkillers and mood elevators. So we know the various types of exercise, but the most important thing is just plain walking would not do. So aerobics is for cardiovascular health. Strengthening and resistance training is very, very important for muscle. Flexibility and range of motion for muscles and joints. Balance and posture to prevent falls. Breathing exercise for respiratory system and Kegels for pelvic floor. We in our country, India has given yoga to the whole world, and we have certain yogasanas which are specific for menopause and its well-being. So Vrikshasana and Trikonasana, all these things are really very helpful. And of course, the Surya Namaskar really helps a great deal. So even the global recommendations on physical activity for health by WHO stresses a lot on this. 30 minutes of moderate physical activity on most or all days of week, weight-bearing exercises, strength training, and balance training. That is very, very important for fall prevention. But it's really boring to do an exercise. So to sustain exercise, do something new, or maybe cycling like that, or pick activities you can easily work into your day, like walking up and down, not taking an elevator, and find a friend or group to exercise with. That really sustains exercise. And the North American Menopause Society stresses a lot on breathing exercise. Just plain inhalation, a long inhalation, holding for some time, holding for a second, and then exhaling through mouth, which if done for about 10 to 15 times twice a day, really seems to help a great deal. And of course, mindfulness is stressed a great deal. Mindfulness in talking, eating, or exercising, mindfulness in all those things what we do. And this is also the suggestion by the North American Menopause Society, guided imagery and meditation. We know that vacations reduce stress, but not all can go. The cost can be prohibitive, or you might not get time. Try a brief mental vacation using guided imagery to achieve a state of deep relaxation. Close your eyes and visualize a scene from your memory that brings joy. Try to get lost in that event or that image for several minutes allowing your mind to return to that pleasurable experience. And we know that certain foods cause lot of stress. So like probably salt, the sugar, then oil, fried foods. So all these things, junk food, all these cause a lot of stress. And Hippocrates said, let thy food be thy medicine. And of course, our Deiva Pulavar Thiruvalluvar also said, Marupadu illada undi, Maruthunin Urupadu illai uyirku. The same thing he stressed. So healthy eating reduces risk of physical health problems like heart disease and diabetes. It helps with good sleep, better mood, improved memory, and energy levels. We know that a healthy menopausal diet really stresses a lot on phytoestrogens, which are found in soybeans, chickpeas, red clover, oil seeds such as flaxseed, ali vidai, which are also found in cereal bran, whole cereals, vegetables, legumes, and fruits. They also prevent hot flushes, and broccoli has a positive impact on the estrogen level and beneficial for maintaining bone density. And it is very important to drink less coffee. That is very, very important. Not more than 200 milligrams per day of caffeine, and consume a minimum of 500 to 600 ml of double-toned milk or a fat-free milk or curds, low fat, to build the calcium bank in bones, and support it with lots of vitamin C rich fruits and vegetables to favor calcium absorption. Lycopene also, this study is from our own AIIMS, where they talk about lycopene protecting women from increased risk of osteoporosis and heart disease. Usually, we do not have drugs to increase HDL, which is cardioprotective. But then this lycopene decreases the bad cholesterol LDL and increases the good cholesterol HDL. So daily high intake of fruits and vegetables increases lycopene levels. So our Indian Menopause Society gives a healthy menopausal diet, 2000 kilocalories daily, 100 grams fruits, 300 grams vegetables, mixed protein, whole grains, beans, that is very, very important, lentils, fiber, phytoestrogens, combination of cooking oils, monounsaturated fatty acid and omega-3, limit oil use to 2 teaspoons per day, which seems to be really very difficult, adequate milk and curd, restrict tea, coffee, sugar and salt, so that and a good breakfast. So this paper talks about ketogenic diet and menopause. So this diet seems to be very effective for weight loss, and hot flashes are ameliorated, and menopausal women have reported that their mood, memory and ability to concentrate improved once they switch to a keto way of acting. Stress can adversely affect sleep, quality and duration, while insufficient sleep can increase stress levels. Stress and insufficient sleep lead to physical and mental health problems. So IMS gives some tips. Go to bed and get up at the same time each day. Sleep in a dark, quiet room at a comfortable temperature. Avoid large meals, exercise, caffeine, nicotine, and liquid 2 hours before sleep. Maintain dim light bedroom environment with no gadgets around. Plato said there are physicians for the body and physicians for the soul, although the two cannot be separated. So it's very important to address the spiritual, mental, and emotional well-being too by prayer, meditation, pursuing a hobby, continue to work, read, bond with family and friends, and participate in social activity. We also have a lot of mind and body-based therapy, cognitive behavior therapy. Psychiatrists, psychologists are very good at it, and it really ameliorates vasomotor symptoms and improves sleep. Paced breathing that also relieves anxiety and controls hot flushes, and hypnosis improves sleep and hot flushes. Acupuncture, magnetic therapy, reflexology, chiropractic interventions, there are no evidence. We know that from the 4th decade of life itself, muscles start really weakening. So that results in sarcopenia. Adults lose 3 to 5% of muscle mass per decade, and rate of decline increases to 1 to 2% per year after the age of 50 years. So it's not enough if you walk alone. It is very important to exercise the various muscles in a structured format. Then after menopause, we see osteoporosis due to the lack of estrogens, which results in accelerated bone loss. We should understand that osteoporosis is a disease of adolescence manifested in menopause. So the bone mineral density peak accrual starts in adolescence, and it's very, very important to encourage all these adolescents to actually bank their bone mineral density. The more they exercise, the more they eat healthily during adolescence, that results in good bone mineral density. So the average age of menopause is earlier for us. So the age of osteoporotic fractures is also early, about 10 to 12 years. And it's really sad to note that 1 out of 3 females in India suffer from osteoporosis. All varieties of hip fracture, then Colles fracture, spinal fracture, all these are seen. And we have to note that 20% die within 6 months of hip fracture, and 10% have a second fracture within a year of the incident hip fracture. So it's very, very important that we have to really see to that osteoporosis is prevented. And as OGIans, we should know when to recommend bone mineral density. So all women 5 years beyond the age of natural menopause, they have to undergo DEXA. Women less than 5 years since menopause, but the risk factor, probably they are on glucocorticoids, or they have some autoimmune diseases like rheumatoid arthritis, women with fragility fractures, radiological evidence of osteopenia, and presence of vertebral compression fractures. Nowadays, even adolescents, when X-ray chest is taken for something else, radiologists report about osteopenia. And of course, before initiating pharmacotherapy for osteoporosis. So, menopausal hormonal therapy is the most appropriate treatment for the prevention of osteoporosis on postmenopausal women before 60 years or within 10 years after menopause. So it's very, very important to think about doing a DEXA and treat accordingly. And vitamin D is also very important. Although we have lot of sunshine, but we have low levels of vitamin D. This deficiency is associated with increased risk of falls and fractures. So it is very important to supplement with vitamin D. Adults less than 50 without osteoporosis or conditions affecting vitamin D absorption, 400 to 1,000 international units per day, more than 50 years, or high risk for adverse outcomes from vitamin D deficiency, like recurrent fractures, osteoporosis, or comorbid conditions that affect vitamin D absorption, 800 to 2,000 international units daily. Calcium, we know, is very, very important. We have to go through the calcium intake in their diet, and the postmenopausal woman needs about 800 milligram per day. The most important thing is fall prevention. So handrails and bright lights in stairways, good support shoes with non-slip soles, keep items within reach, and clear the path to the bathroom, phone and electrical cords away from walkways, regular vision examination, avoid medications which can make you dizzy or sleepy, and urinary incontinence. So when they just run to the bathroom, they can have a fall. So it's very important not to just bend from the back, but to bend at the knees. Menopausal hormonal therapy should be used as a preventive and not corrective therapy. This is very, very important. And treatment should begin in menopausal transition for hot flushes and sweats, sleep problems, mood swings, feeling down, and pain during sex. And the most important thing is the critical window, less than 10 years after menopause. When it is started, it reduces the risk of all-cause mortality and also coronary heart disease. So we have a lot of methods for easing hot flushes. This is by Australian Menopause Society: avoiding hot and spicy food, avoiding alcohol, reducing stress, and hormonal therapy. The local estrogen therapy for vulvovaginal atrophy that improves quality of life, not only for the woman, but also for her partner. And India being the diabetic capital of the world, we should understand that menopausal hormonal therapy reduces the risk of type 2 diabetes by 20 to 35%. So this, I think we should really take a look into. This is the absolute risk of breast cancer. Even for those with BRCA mutation, there is no evidence of a greater increase in risk with menopausal hormone therapy than that in general population. This is the group by Hereditary Breast Cancer Clinical Study Group. And here we see that an estrogen and progesterone therapy results in 5 more cases of breast cancer. Tobacco, 3 more cases, but see obesity, which is really the pandemic now, 24 more cases of breast cancer. So it's very important that we have to institute lifestyle management, such as increase the physical activity, reduce obesity, and reduce the alcohol consumption. So menstrual hormonal therapy in an appropriate patient with appropriate drugs in appropriate dose through appropriate route with appropriate time of initiation and for appropriate period. This is what our Thiruvalluvar said, Noi Nadi, Noi Mudal Nadi, Adutadikum, Vai Nadi, Vaipachayal. And India is having an epidemic of non-communicable diseases, cardiovascular disease, cancer, chronic respiratory disease, diabetes, mental health conditions. So 1 in 4 Indian has a risk of dying from an NCD before they reach the age of 70. So screening for diabetes, hypertension, and lipid disorders is very, very important. So we also know that 1 in 28 Indian women have a lifetime risk of developing breast cancer. 1 in 45 women have a lifetime risk of developing cervical cancer. 1 in 78 women for developing ovarian cancer. So self-breast examination from the age of 20 every month, and clinical breast examination every year from 30. Mammogram annually from the age of 40 up to 75 years in high-risk women, from the age of 50 in women with average risk, and cervical screening by pap smear every 2 years from 30 years. Ideal would be HPV DNA testing every 5 years. That is very, very important. And of course, for the youngsters, primary prevention of cervical cancer by HPV vaccine. So scanning of abdomen in dyspepsia and abdominal distension to rule out ovarian cancer and not summarily reject. So all these things are very, very important because cancer can cause lot of stress. So for a stress-free menopause, healthy diet, regular exercise, positive attitude to life, engaging in hobby, work of choice, or housework or community work, no smoking, minimal alcohol consumption, vitamins, antioxidants, hormone therapy where indicated, and appropriate screening for diseases. So aging happens, but good health is planned. So to save menopause from stress, we have to follow all these measures. I thank Dr. Sampath Kumari for having given me an opportunity to share my views on save stress from menopause. I really enjoyed it. Thank you.
Fantastic, madam. Fantastic. Have covered everything.
Listening to you, madam, it was really another fantastic presentation, and you had aptly completed the entire whatever are the problems pertaining specifically to menopause and all the non-communicable diseases, which definitely needs to be screened. And you have stressed the importance of diet, lifestyle modification, medical and other management. Very beautifully. It was really fantastic having you, madam, with all those between quotes. So much for the excellent lecture, madam. Thank you.
Thank you very much.
Thank you, Shanti ma'am, and thank you, Viji. We'll move on to the next session now to introduce the chairpersons. Can I have the slide, please? Yes. Dr. Radha Madhavi, she is founder president Thiruvannamalai Obstetric and Gynecology Society. She's a practicing gynecologist in 1994 and currently director Rajam Multispecialty Hospital and Rajam Institute of Paramedical Sciences. She's joint secretary and EC member TNFOG and member ISAR and IMS. Can I, next slide please? Can I have the next slide please? Dr. Vairamani, she's done her PG from Madras Medical College. She's been on government service for 10 years and she's currently running Vairam Hospital, Namakkal. Thank you. I now request chairpersons to take over the session. May I request Dr. Radha Madhavi to introduce Dr. Palniyappan.
Good evening everybody. Good evening seniors and friends. Thank you madam for the kind introduction. And it is a great honor and privilege to introduce Dr. Palniyappan, whom I know since almost 30 years as soon as I finished my PG. Dr. Palniyappan, I think everybody knows. But still, he is a professor and unit head Department of OBG, Sri Ramachandra Medical College, Chennai. He won the Indumati Javeri Award 1994. That's what I told you. Young Health Scientist Award in 1996. A.L. Mudrial Traveling Fellowship Award 1998. Senior Overseas Fellow, Liverpool Hospital, Sydney. Kamini Rao, Yuva Foxy Orator, Young Gynecologist Awardee of the Asia Oceania Federation of Physicians, AOFOG 2007. He is the invited speaker at various national, international conferences, author of many chapters in textbooks. He is interested in high-risk obstetrics. He is the Joint Secretary of the All India Congress of OBG 2015, Chennai. President, OG Society of Southern India 2020, and he is chairperson of the Safe Motherhood Committee, FOXY 2017-19. And his presence lights up many of the conferences. He adds humor to knowledge. Thank you, sir.
Thank you, Dr. Radha Madhavi and Dr. Vairamani. Good evening to all of you. And hi, Niharika. If Sri Lakshmi Sri Khande and others are there, good evening. And thanks to Dr. Sampath Kumari and Anjalakshi for having put me into this wonderful session of Save the Dash conference. CME, and I'm extremely happy to say that we are here to save the uterus and not to pluck out uteruses from women. And after Dr. Shanti ma'am's talk, I'm just enamored what we should do for menopause and things like that. I was just wondering if there is an andropause clinic and we should think about having talks on andropause as well. So let me start sharing my slide here. You're able to see my slide?
Yes, sir. Yes, sir. Yes, sir.
Yeah, clear?
Yes, yes, clear. clear.
So now I'm here to talk on a subject which is quite dear to me and save the uterus, and that's what is going to be for the next 15-16 minutes, and tell me if I overshoot time. And I was just thinking that we can't save the uterus in conditions where we have malignancy, and so let us not touch on malignancy, and so we will touch on very few select topics of AUB, and let us see whether we can save the uteruses in these conditions. And the ACOG and other national organizations have endorsed now into 9 categories of disorders. That's the PALM-COIN, and I'm sure you know the PALM-COIN classification. Let me not go into that, and of which we will not touch many of them. We will touch only a select one of them, a few of them. And what I thought was, it is quite easy to think in terms of Panchabhuta, that is the water, fire, air, Akasha, and earth, which are available surrounding the environment and is able to keep us healthy. And so we need to protect the earth, protect the ecosystem, protect the environment, protect you and me, and as well as protect the uterus. And so do we have something to say that can we protect the uterus by features like the Panchabhuta? I've just compared the features of Panchabhutam here to that conditions of uterus of AUB, where we can see whether we'll have to remove or whether we'll have to keep the uterus, etc. Do we have alternatives to treat, and can we conserve the uterus? So water, I'm sure all of you would know, is one of the biggest Panchabhuta, and we knew how the floods in Chennai affected some time back, and still we are worried. But at the same time, in summer, water is very essential. We don't get water in Chennai, and I'm sure water scarcity all of us would pass to. And so we would know what is the importance of water, and so we need to keep the uterus as saved as possible and keep water saved as possible. Comparing AUB polyps to that of water, why I've compared the AUB polyp to water is that because only with the water we can produce a distension of the uterine medium and take out and not remove the uterus. So that is the alternative we have. And polyps account for 33% of women with AUB. Only 27% of them resolve spontaneously within a year, but the rest of them can be treated with something else. And 1 to 2% of them can be cancerous only in the postmenopausal women. And polypectomy, probably a blind polypectomy or a hysteroscopy, is an alternative option. And uterus need not be removed for a polyp like that. And so there are enough gynecologists who would remove the uterus for a polyp for just simple reason that the lady is 47, 48 or 49 years of age, and we have enough evidence to say a polypectomy would do, and then probably combine it with a hysteroscopic biopsy of the endometrium and pap smear, of course, would do, and not necessarily remove the uterus. And so it is important that we conserve water here and conserve the uterus as well. Coming to the next Panchabhuta, that is the space, which is very big, and we'll have to look upon the space to see what is happening on space, and we compare adenomyosis with that of space. That is very important, and the treatment of adenomyosis has reached beyond the space, and that's why I've compared adenomyosis with that of space. Heavy bleeding, HMB, possibly related to the depth of penetration of adenomyotic gland, is a reasonably new classification which came in some time back, but then is not very popularized. Whether it's grade 1, only adenomyosis subbasalis, grade 2, penetration beyond the mid-myometrium, and grade 3, penetration beyond the mid-myometrium, but grade 1, 60% had HMB, and grade 2 and 3, only 42% of them had HMB. So we need to understand that can go in for grading as well, and we have enough medical management based on the available features. You have the LNG-IUS, a danazol loaded IUS, which is a reasonably new concept, which is not come into India fully. The GnRH agonist, and of course the aromatase inhibitors. The LNG-IUS, I'm sure all of you would know, is popularly called as Mirena. 20% of women on LNG-IUS were amenorrheic after 1 year of usage while still continuing to ovulate. It cures dysmenorrhea too. Intramenstrual spotting and bleeding during the first few months is a disadvantage, but it deserializes the endometrium, followed by arthrostic changes and reduces the mean blood loss. The downregulation of the estrogen receptors, deposits shrink in size with the usage of LNG-IUS over a couple of months. Coming to the danazol IUS, popularized by the FT, Fuji Latex, Tokyo, Japan, very popularly and well used in the Japan, but then we are not using it much. It's not yet come to India. contain 300 to 400 milligrams of danazol. Danazol is a drug which has been available some time back and has been given off because of its androgenic side effect. And I don't think any of us use danazol. And I've been taught to the students, and I teach my students as well, that if you write danazol and say we don't use it, you will get 1 mark on the short note or an essay question. But that was the scenario some time back. But now IUS danazol is available and can be used similar to the copper IUD with a thicker anteroposterior diameter and no systemic effects of danazol, and it is quite a novel conservative management for adenomyosis. Coming to the GnRH agonist, you could use similar to any endometriotic effect for 3 to 6 months of the pre-op blood loss and size of the adenomyotic nodule comes down. But then there were times when we used the GnRH agonist and then we came back because we had better drugs available. And now we have the aromatase inhibitors, the anastrozole. Anastrozole is quite very well used while you're using with the GnRH agonist as a combination. They're found to be quite effective. Do we have any new novel techniques to save uterus in adenomyosis? We have the uterine artery embolization. Sorry. We have the uterine artery embolization and yes, and of course the MRG FUS, the magnetic resonance guided focused ultrasound. What happens in these two methods which are available, but then we don't do it very often for the very simple reason that it needs to be popularized. 1, 2, it is expensive. 3, it has got its own disadvantages in the sense that when you do an MRG FUS, the adenomyosis can be in the posterior wall, whereas we'll have to focus when the patient lies inside the MRI chamber, the rays have to pass from anteroposterior. When it is in the posterior wall, we have to make them lie in the prone position, supine position. In a way, like as though whether your chapatis and dosas have become well or not, you turn them up and down, and that's what happens in MRG FUS. And very cumbersome to turn inside a MRI chamber, and MRI chambers are now, of course, becoming claustrophobic after the COVID and the CT consoles. So that is a disadvantage with the HIFU, the MRG FUS, and of course, uterine artery embolization also, which is not very well popularized, but documented, and we have evidence to say so, but we don't have much experience, and probably UAE is used only for a postpartum hemorrhage. Coming to surgical treatment, some time back, we were only thinking in terms of hysterectomy, but then surgically, Cullen distinguished 3 classes of adenomyosis, the submucous, intramural, and of course, the subserosal and retroperitoneal adenomyosis, which we thought was not a very good classification, but then this is the correct classification we need to think in terms of, and this is the Donna's classification, where you have the type 1, where the retrovaginal septum, type 2, the posterior vaginal fornix nodules, and of course, type 3 is a diabolo-like rectocervical nodule. This is the retroperitoneal adenomyosis and not uterine adenomyosis. For such a case, removing the uterus would be a stupidity to do because the patient will continue to have pain even after you have done a hysterectomy and you have forgotten to save the uterus, but still the pain will of course be saved very well, and no doubt about it. If you don't remove the nodules here, she will not be benefited out of a hysterectomy. So please don't blame the uterus always when we have a Donna's classification like this and the adenomyotic nodule sits outside the uterine cavity and not inside the uterine cavity. And this is the type 1, the type 2, and the type 3 diabolo-like ones which we have done. And here this will be picked up only by an MRI or with a very great clinical document where you'll be able to pick up a rectovaginal nodule. And some people use the Peter Meher's rectal nodule to put rectal probes to put into the rectum and dissect and then take out this. It can be done through the laparoscope or through the open method as well, but that's a surgical method where we need to do and conserve the uterus rather than remove only the nodule, and the patient will be benefited though. That is about adenomyosis. How can we save the uterus? And now coming to Earth, the place where we all live and the place which rotates all around sun and moon, evolution and revolution. What happens is that the biggest leiomyomas where we compare them, and that is what is about the Earth. And these are globular nodules like Earth, which revolve around treatment options for women. And that is what we need to conserve the uterus. And this is a myomectomy specimen, which we did some time back, where we removed 24 myomas from various sizes, the father, mother, grandmother, granddaughter, whatever. And that is the fibroids which we have removed. We could do a myomectomy, which we'll touch upon last and not go into details, but then there are enough medical options for a myoma as well. You could have a menu card like approach of armamentarium of medical management available for the treatment of myomas, and still we resort to surgical management here. But anywhere in the US and UK, a surgical option for a myoma would probably be the last of the option, meaning which they would conserve uterus and conserve resources in so many other ways as well. Coming to the GnRH analog, you could give the Leuprolide, which is 3.75 a month or 11.25 once in 3 months, the depot preparations. And we have enough advantages and disadvantages written by our own Dr. Shankaran and Manyonda in the beautiful COGs, and we would only think in terms of using them for most of the cases some time back, because we did not have any other drug available 15 years back, but now we have other options of medical management of fibroids as well, apart from GnRH analog. So what is the role of GnRH analog? Definitely they can be used in women with Jehovah's Witness and women with a submucous fibroid of greater than 4 centimeters diameter, where the access into the uterine cavity to carry out resection might be compromised, and in women where the submucous myomas may be a problem in infertility cases. There you could use them without a surgical option, and then conserving uterus as well as conserving resorting to a medical management. You could use raloxifene sometime back. We did use it and then we came back, but then raloxifene with the GnRH agonist works very well. The study here said GnRH agonist with raloxifene or with a placebo for 6 months. Raloxifene did not ameliorate the menopausal symptoms, but reduced bone loss and act synergistically to reduce the fibroid volume was something which we came out of the Columba study, a very famous study in the year 2004 and published in Fertility Sterility. You could use the antagonists, of course. Yes, US FDA approved 5 milligrams of cetrorelix twice daily for 2 days, and of course 0.0 to 8 milligram twice daily for at least the next 3 months. Acts directly on the pituitary GnRH receptors, and discontinuation leads to a rapid recovery of the pituitary gonadal axis. Larger studies are needed for this particular drug. We have the SERMs, which we used some time back, 60 milligrams of menopausal, but then in the menopausal women, but less effective in the premenopausal than in the postmenopausal women, and we need more studies for them. And of course, it had deleterious effects on the heart, and we knew the root study which came out, and so we had plus and minus of using the raloxifene, and probably we did not use raloxifene very much. The newer ones which are available now are the aromatase inhibitors, very well used now. The anastrozole, which I was telling you when we were discussing about adenomyosis, very well done in fibroids. The Connect study, which said that decreased dominant size fibroid, thinning of the endometrium and cessation of bleeding, and the Fadrazole is used again in Japan very well. 71% reduction in fibroid volume in 8 weeks, and all of them did not have much side effects, and we are still yet to use them. We're looking forward to have anastrozole and Fadrazole in India, because I'm sure we will be benefited out of that by saving the uterus. LNGIUS, as we did study, we had the Latin Marquis study where they compared this with the surgical women on the waiting list. 64% of women canceled their surgery for a fibroid because they were very happy with the LNGIUS, and there were no long-term randomized control studies apart from the Latin Marquis study. Coming to the most recent one, that is a selective progesterone receptor modulators, the Asuprasnil, and of course the mifepristone and the uliprostol, which is to follow. Very promising, and I'm sure you know that they would cause hypomenorrhea with 5 milligram, amenorrhea with 10 milligram, and of course some of them would cause contraception with a little more, and then pelvic pressure, bleeding, fibroid volume, decrease in size, impact on the bone mineral density, fertility, recurrence rates, and endometrial hyperplasia are being studied, and we have enough evidence to use sperms as well. The mifepristone used as 5 to 10 milligrams per day reduced the blood loss by 40 to 70%, 50% reduction in the uterine size. But the mifepristone tablets which are available to us are either 50 or 100 or 200 milligram tablets. So we need to break them into smaller doses, and dosing is a difficulty. So you have a pharmacist to do that, and that would be wonderful. Or there is a drug company which could manufacture 5 to 10 milligrams of mifepristone. Yes, we could use mifepristone quite well. Coming to the Panacea, which is some time back called as the Esmia or the Ella, now available in so many modifications, is the uliprostol acetate. It's a progesterone receptor modulator, 5 milligrams daily for 13 weeks. 2 intermittent 3-month courses resulted in amenorrhea in 80% of subjects. Fibroid volume reduced by 40%. US FDA approved in August 2010 and got published in New England Journal of Medicine 2010, subsequent to which we had the Pearl 1, 2, 3, 4 studies. But some time back, this particular drug, the Ella alone, had an issue with the liver function test, and for some time we had uliprostol acetate banned its use because of elevated liver functions on an occasional patient here and there. But then what happened was, after that they found out that they need to do a LFT before starting, and then at the end of 13 weeks, they would do an LFT again with an LFT probably at the end of 6 months usage, and then they would withdraw the patient with a progesterone after 13 weeks, and then they would again go on. And the Pearl 2 and the Pearl 3 did a comparative study with, of course, 3 courses of universal and has been very successful, and now it's again being approved for usage in fibroid, and probably this is the Panacea drug which is available for us to use in a fibroid. Myomectomy, of course, is available as the first slide which I showed you. Probably you should need to think in terms of perio blood loss, adhesion formation, and recurrence of fibroids, and choose the particular case very selectively. And but myomectomy is an option to do for a woman at any particular age group, unless or until you're thinking in terms of malignant transformation, which is extremely less. And so these are ways of conserving the earth and conserving the uterus in a case of fibroid. Of course, the uterine artery embolization had its own query of plus and minus, but the EMI trial compared and said it's quite possible to do that. The REST trial did say randomized controlled trial of embolization versus surgical treatment for fibroids said UAE is safe, but then as I told you before, we don't use uterine artery embolizations much very well for a fibroid, except probably for a BPH, we don't use the uterine artery embolization at all. MRGF-US again has its own plus minus. The coagulopathy we will just skip and we would not touch upon, and we would go on to the last one of them, that is the air. Air is, of course, the wind blown all over, and we will be happy if the wind blows towards us. It can destroy the world. Of course, it can save the world if it's quite calm. Coming to the last of the option, the ovulatory disorders and related to the endometrial dysfunction, both of them can be compared to that of the air, because it could be inside and it could be outside, and we could see them, we could feel them. The ovulated disorders, identify causes, hypothyroidism needs to be considered, oral progesterones needs to be given, yes and no are thought, and surgical alternatives similar to the AUBE. And coming to the endometrial dysfunction, where we will take upon the ovary and the endometrium together, which is probably the disadvantages of Palm-Cohen classification, where one of them could overlap into the other, could be compared to that of fire, because the endometrium can be burnt by fire, but not the ovary. The AUB endometrial dysfunction means menorrhagia, ovulatory DUB, local endometrial hemostasis needs to be concerned. And we had enough drugs which came some time back, like the oral progestogens, ethamsulate, danazol, testosterone, vasostriptix, analogs, which, like the Coca-Cola, which was banned sometime back in the middle when it was used for pesticide usage. This is a paper which came sometime back, which I did not want to quote here for disclaimer effects. And then it had its own doubtful effect on the insecticides, whereas it's very good to taste Coke, and I like Coke. But then the question is whether these drugs are of usage. These drugs have doubtful treatment modality promises in AUB. Superiority of the LNGRUS, said reversibility of the LNGRUS, contraceptive benefit, easier access and lower cost, of course, takes over the LNGRUS as probably the drug of choice or system of choice in endometrial pathology. The SMART trial, or sometime which came back quite some time back, said satisfaction of by pictorial charts at 12 months post-treatment of an ablation versus Mirena. The study terminated due to a poor recruitment rate in the LNGRUS arm, and it said, then came the tail study, which said that at 12 and 24 months, the median PBAC scores were significantly lower in women treated with the LNGRUS compared to women treated by thermal ablation. At 24 months' time, women still using the LNGRUS had amenorrhea compared with one woman successfully treated by thermal ablation. But of course, we have other methods of ablation as well, which you need to think in terms of, and we'll see very soon. And coming to Mirena, its meticulous instrument redefining endometrial nature aggressively is the definition which I have put across here. And I'm sure the company, if they take over this, would pay for something called disclaimer rights to me. Surgical alternatives in endometrial pathology in AUB would be the REA and the NREA, which we don't use much in India, and I'm not sure whether anybody uses the REA and NREA. But then, if you could use the endometrial laser ablation or the transcervical resection of the endometrium, a beautiful study came back sometime long back, around 2000, and the Mistletoe trial also came back around that, published in the BJOG. They said they compared the TCRE versus ELA, and they said two less to choose, and whichever you're comfortable with, go ahead and use whatever you've been using to. Endometrial destruction or hysterectomy, hysteroscopic surgery is an accepted alternative to hysterectomy, came published in the Lancet and in the journal long back. And then we need to understand that the hysterectomy rates did not drop significantly, in spite of saying that the endometrial ablative procedures are as comparable to that of hysterectomy. But the hysterectomy rates did not drop significantly all around the world. Why? Because of amenorrhea, reoperates were higher, and learning curves of hysteroscopy were also always to be considered. But for whom is ablation? For a lady with heavy menstrual bleeding, not expecting amenorrhea, ATP are excluded, uterine size less than 12 weeks, no pelvic infection, completed family, fit for surgery, and last one, who would go for a hysterectomy at a later date. But who are the women who would go for a hysterectomy later date? We don't know. We don't know who are the women who would go on after this firing procedure of endometrial ablation. So what to expect from ablation? You cannot expect 100% satisfaction, 80%. You could expect lighter periods. You could expect amenorrhea in 40% of them, but cannot predict in which women they will have amenorrhea and who are the women who will fall into that 60%. Of course, dysmenorrhea, very less, PMS, less, risk of hysterectomy between 10 and 25% after 3 or 4 years of age. So if you choose a woman around 45, 46 age, to do an endometrial ablation, she would cross this 3 to 4 years of age, and then she would attain menopause quite smoothly. But then we need to understand that she's got a 10 to 25% chance of hysterectomy at later date, and we need to counsel her before doing an ablation. But it's a procedure which is quite satisfactory and easy to do. Whatever method, whether the first generation, second generation, or third generation, you could do, and you could save the uterus. A procedure which came up and then went back like the rise and fall of whatever dash. And so to conclude, saying palm coin terminology of ACOG seems scientific to classify AUB. MRI seems to be better in diagnosing adenomyosis. LNG, IUS, GnRH analogs, urinary embolization, aromatase inhibitors, robotic surgery are worthwhile alternatives to hysterectomy in adenomyosis and, of course, myomas. Ulipristal has probably revolutionized the myoma treatment, but to be used with caution. Lap myomectomy has newer innovations. Endometrial ablative procedures without hysteroscopy are viable options in endometrial pathology, whether it's 1, 2, or 3 stages of, types of endometrial ablation you do. Hysterectomy probably is reserved only for the last resort and doubts of malignancy. Where women are honored, their gods are pleased, but where they are not honored, no sacred right yields rewards. When the female relations live in grief, the family soon wholly perishes, but that family where they are not unhappy ever prospers, says the laws of Manu. And AUB probably sometime back was thought as abnormally uterus blamed, but ladies and gentlemen, absolutely uterus can be balmed. It need not be removed. It need not be crucified, cut, and sent to the histopathology lab. And of course, ladies and gentlemen, let me end up with the last video clipping, which I would not part with because Dr. Sampath Kumari would not excuse me if I don't put a video clipping of the Panchabhuta here. This video could probably be used rightly. That's exactly the terminology, why I put this last video here. Before I could switch it on, let me say, uterus to be removed only when it is indicated, and Panchabhuta should be used safely, effectively to preserve us and not to destroy us. The right way of dancing.
శాస్త్రీయ నడనమా எந்த சம்பிரதாயம்
எத்தனை சம்பிரதாயங்கள் இருக்குன்னு தெரியுமா உனக்கு? இத பரதநாட்டியம்னு சொல்லுவாங்க.
Ladies and gentlemen, thank you very much for your patient listening. Happy to answer questions.
That is Dr. Parni.
Arumai, Mika Arumai.
Chat box la unna question illana, we'll go to next topic. Rajshri, chat box la enak theriyilla
question illa ma'am.
Then wonderful, Dr. Palaniyappan.
Thank you, Sampath ma'am, and thank you, Radha Madhavi and Vairamani. Thank you for chairing my session. Thank you very much, and eager to see Neharika speak next.
Dr. Vairamani.
Madam, good evening. Good evening to one and all, madam. I would like to thank, first of all, the TNFOG president and secretary, madam, for adding me as a chairperson in this scenario, madam. Thank you for that. I would like to introduce Dr. Nikarika Malhotra, madam. He's an MBBS and MD, DRM Fellowship and Reproductive Medicine. He's now consultant at RAIDPO IVF Center. He's a chairperson at Foxy Young Talent Promotion Committee 2020 to 22, then joint secretary Foxy 2018, assistant editor journal of IJHWD, madam, active member of so many committees, madam. He won so many awards, madam. Over to you, madam. Thank you.
Thank you so much, ma'am, and very good evening to everyone here.
Yes, Nikarika.
Madam got so many awards, I can't even read.
No
Wonderful, ma'am.
problem. Thank you, ma'am. Thank you so much. And special thanks to Ramani madam, Vijay Lakshmi ma'am, Cynthia madam, and Anjalakshmi madam for having me here and on a topic which is very close to my heart. And we have been discussing the whole evening on various topics like save the uterus, save the menopause. Nothing would have been possible if we do not save the girl child. And that's what I'm here to talk about today. We understand that the best thermometer for progress of any nation is its treatment towards their girls and their women. There is no chance for welfare of the world unless the condition of our girls is improved. The status of our girls have been a discussion, grave discussion for many, many years from now. It encompasses various burning issues like education, empowerment, economic empowerment of females, role of female in the family, and of course, the most important one as the female feticide. When I talk about girl child, we understand that in India, being a girl child is very, very challenging because of the discrimination and humiliation which has been seen since the day the girl child has been born. Why is this being happening? Because if you read the Rig Veda, women enjoyed equal status with men in different walks of life. Women back then were educated and had freedom and were respected. And there was history which suggests that women were only married at a mature age and they had the right to choose their husband through a process of swamvar. But slowly, as we see, the times have changed. So did the position of women across. And now early marriages, sati system, the parda system started becoming popular. Society began to judge masculinity by limiting the women their places, especially with the Rajputs being the Indians' most masculine community, began to adopt other practices like Johar. And also we had seen South India practice the Devdasi system. And that's how the history began to change. When you ask a question, even today, that do you really want a girl child, you would see most of the people, almost 60% of them will say no. Some will say, I don't know. A few of us would say, of course, yes. Even today in India, Indian villages, even cities and metros, people still remain apprehensive. And it's not just because of having a girl child, but also educating a girl child, also being insecure of having girl child in our houses. Ever since a girl child is born, there is discrimination at every step. Our society still continues on the preference of a boy child. When we talk about India being a happy country, India is not a happy country. It's not even on the top 10 of the happiest countries in this world. We are at 118. And what do we lack? When we talk about the happiness report, which has been done at 2020, there are things which have been importantly seen that India is below because we lack women empowerment, because we have poor environment for our girls, and we lack the generosity, kindness, compassion, and friendship, which is an important factor. Our Indian scenario, the real picture is that women are suppressed by gender bias. There is seen a want of male child. Female child are usually not welcomed. And there are centers which offer services even in urban and rural cities for sex selection even now. Throughout the world, there are social norms in some form or the other which deny women to the right of education, right of health services, right of political participation. One study in United Nations did say that women constitute almost 2/3 of the world's illiterate population. And I don't think we should be proud about it. How all this actually began? It began through a very long time back in 1980s when genetic testing was a breakthrough in India. Then the test abuse for sex determination started. A lot of NGOs started talking about altered sex ratio in 1990s. And then the government committee came on the PCPNDT Act, which was modified along the way. A lot of clerical administrative forms started to be filled by doctors, and doctors were taken through a punishment for even mistaking in filling those forms. And there was a lot of misunderstanding and misinterpretation, which led to a lot of harassment. Yes, we all, through government, Foxy and IRI, are now working towards simplifying this deal and also accusing the actual crime. When we talk about son preference in India, it's one of the most important cultural norms which is affecting our society, because people, when they get a son, understand that there is benefit of having a son in economic utility, socio-cultural utility, and religious utility. Whereas a daughter is considered as a liability, has dowry system in us, of course, systems of heavy cost weddings. Yes, we all understand the important thing as female feticide, and it is something which has to be stopped right here, right now. We Indians call ourselves as Mother India. We are devotees of many forms of goddesses in our world, but there is some kind of double standard which you're all going through. The reasons why India is poor or India lacks this Save the Girl Child issue is importantly because of poverty. Second important is gender discrimination. The most important, as I would say, is education. Then traditional practices which come. When we talk about the female sibling, if I have a son and if I have a girl child, we all see that male children are likely to be fully vaccinated. Boys are more breastfed for a longer time. Educations to girls are mostly restricted, and as soon as they attain menarche, most of them stop educating their children. Also, if you see the infant mortality rate, and you can see there is always a rise in the female infant mortality than the male child, because male child are looked after better, even though female children are survivors. The things I'm telling you are just the tip of the iceberg. India's sex ratio is poor, we all understand. And most of the states where you can see it's decreasing, especially during COVID, we have seen a drastic decrease in the sex ratio, also in the education of the female child and literacy rate of our women. Girl child education has to be worked upon few states like Rajasthan, Gujarat, Madhya Pradesh, especially Uttar Pradesh. I come from Uttar Pradesh and it deeply pains me to see the situation of girls here. Most of the girls get married by their 18th birthday. 60% of our girls are undernourished, and 1 of 20 million girls worldwide have experienced sexual violence. So where are we heading right now? We have to understand that when girls are given equal opportunities to reach their potential, they are powerful agents to change. And that's what we have to propagate. As doctors, during our pregnancy phase, the family, the mother has to be taught that whether it's a girl or a boy, equal opportunities should be given. They have to be made to understand that girls have to complete their primary education, because if a girl completes her primary education, the maternal deaths will reduce to up to 66%. If a girl or a woman equally participates in our global economy, our GDP will increase. And if women are there in politics, there will be peace building solutions which are long lasting. So there's a huge advantage of education. Yes, our law is working towards this. A law prohibits marriage of minors. There is a Prohibition of Child Marriage Act. PCPNDT Act is also there. There's MTP Act, which is working towards until the age of 14, Education is being given in some places for free, and mandatory schooling is being provided by the government. This law has to be reinforced by all of us. Law also protects our girls from prostitution. Law protects our girls from prenatal diagnostics techniques. And this law now has to go towards places, to smaller cities. Our government is really working hard on providing financial security to children, especially by the Sukanya Samriddhi Yojana. Adolescent girls are now becoming more aware of their health and career options. So as our aim is, even in smaller cities, we should together unite in educating our girls and ending child marriage. I think these two things are the important factors which will help us in saving our girls. A lot of countries have been working towards reducing their child marriages, but we are far way behind. We have to understand that child marriage has to be reduced, because otherwise the girls will not get chance to complete their secondary schooling. If there is child marriage, they'll have less decision-making abilities in their household and face more risk of domestic violence. Ending child marriage is good for our economy also. 5 important reasons when we talk about girl education to everyone is improved health and hygiene, economic empowerment, a decision-making empowerment, enhanced self-esteem, and of course, socio-economic equality. So this was an important chart which I heard when we were doing, I run an NGO on women empowerment and Save the Girl. And it's important to understand the impact. There has to be an access for education, completion, the girl's ability to stay, participate and learn, and then transition, the girl's ability to move to a transitional phase. In India, it's seen, we may have the access, but the completion and the transition is where we are lacking more. And that's where are the steps we have to work about. When I talk about working towards Save the Girl Child, we have done a lot of work in Agra, in our society, in our NGO, and we've got a group of like-minded people working on environment, education, awareness through one-on-one talks, group sessions, and public sessions. And that's what I would want you all to do in your cities, because we have to change that perspective towards women and overcome that patriarchy which is happening and block the loopholes in legal structure. Sensitize and educate men to respect women is very, very important. So what we do in our city right now is, from 2008 onwards, we conduct yearly annual Save the Girl Child rallies, where schools are invited with other NGOs to participate on the theme of Save the Girl Child. Children come with posters on how they should improve education system and how it should go ahead. And that's how the rally gets conducted every year. Second important thing which we do is we identify underprivileged school where they teach children for free or for basic minimum fees, and then help them develop their educational system. Right now with our NGO, we've adopted many schools and we're providing them free books. We are helping children who cannot continue their education by providing them fees, school uniforms, etc. And we also participate regularly in their annual days and functions to motivate the teachers to come forward and help them. Regular health camps are conducted throughout the city every 3 monthly to improve the health of our women. We do group sessions and talks on various topics. And of course, something which is very close to me, let's spread kindness wherever possible. Never leave an opportunity to help educating a girl child, even if it is in your hospital or somebody you know, house help who cannot educate children. Provide them with some help and it'll go a long way. Together, let's join hands with other associations. Especially we have such a strong association called FOXY. We have the Human Rights Organization, which is working on girl education. We have Club 35s everywhere, Rotary Club, Lions Club, and local education NGOs. So identify people around you and go through it. Actually spread awareness in whatever way possible through charts in your OPDs, sending charts to schools and colleges, and improving our outcomes. Another important thing to add is support your locals. We all go and buy from the malls, but I think it's high time we change that and help the locals come forward, because if they start earning minimum wages, they will start educating their children also. Everything goes hand in hand, from education, empowerment to environment. And that also should be stressed upon with our education system, that we have to work towards our environment also. Every year we perform annual Nari Shakti Samman, where we bring in young entrepreneurs who have been working in the city and give them to give lectures on how they have crossed the barrier and come forward, and let them motivate other girl children around them. And that's how improving the quality of a girl child education in my city. We celebrate every girl child which is born in our hospital. So together, let's bring a change. Raising social consciousness is very important. Celebrating the birth of girl child is important. Setting a support system for our women and society vigilance groups, and strengthening our government response mechanism. As I end, I say, one child, one teacher, one book, one pen will change the world. And when that child is a girl, you will change in generations. So thank you everyone for having me here. And I hope I have done justice to this talk, Sampath Madam. Thank you.
Yes, Neharika, you are the only one who can do justice. Thank you. Vairamani, unmute. So only I told Neharika.
Madam, very excellent talk, madam. Really, you did a wonderful work in your place.
Yes, thank you, Vairamani. Fantastic.
Thank you, Neharika, madam. Thank you, Vairamani, madam. Thank you.
Neharika, it was truly a very inspirational talk. Okay, so I mean, like, definitely people who have listened would have had that inspiration of we have to do something, if not in a large scale, at least to whatever extent possible, we will definitely try to do. Excellent, excellent. You've done a very good job.
We have around 130 registration. Hope at least this 130 people should do that.
Yeah, sure.
Niharika, it was an excellent talk. Really, no, a very beautiful talk. Beautiful talk.
Thank you. Thank you, Neharika.
Thank you so much.
In person to Chennai.
Yeah.
Okay. Dr. Rajshri?
Yes, ma'am.
Ma'am, we'll go on to the last end of the thing. Rajshri is going to introduce me again. So, vote of thanks. So, I will start it myself. There no need to put the screen there now. Please close that. Everyone has been introduced already. Thank you, Rajshri, for introducing me. It is really a proud privilege to propose the vote of thanks to this August gathering. And I don't know why Sampath Madam always chooses me to say thanks, but it's really Nandri Marappadu Nandrandru. So Nandri solvadu really a very, very big thing. And Anaivarukkum Nandri Mudalla. So first of all, on this Women's Day special program, a CME on healthy women, the organizers, definitely our TNFOG President Anjalakshi Madam and our Secretary Sampath Madam have really chosen an excellent topic and excellent speakers. Thank you so much, Madam. And excellent chief guest was chosen, Dr. Cynthia Alexander. Madam, we really thank you. If I remember correct, you were the chief guest for the first CME program ever of TNFOG, I think. And we are really proud to have had you today as the chief guest, Madam. For the first session, we had our chairpersons, Dr. Mary Ann, Dr. Chitra, and Dr. Saroja Madam, who could not join. But anyway, thank you all so much, chairpersons, for your valuable time. And Dr. Lakshmi Shrikande and Dr. Girish Mane, fantastic talk by both of you. Really, you have taken time to join us in this program. And our dear Shanti Madam, thank you so much for your excellent talk on menopause. For the second session, we have had our chairpersons, Dr. Radha Madhavi and Dr. Vairamani. Thank you both of you chairpersons, and our speakers, Dr. Palaniyappan sir and Dr. Neharika, who both did an excellent talk by both of you. And as usual, Palani sir's very glittery and cinematic talk, and definitely the entire program was fantastic. On the theme of SAVE was really great, and all the speakers have done justice to it. And I'm sure the 130 delegates who are logged in here Thank you all so much. Without you people, the program will never be a successful one. Thank you. And we have taken home all the saved messages. I hope the entire CME was very useful to you. And first and not the last of ma'am.
Rajshri.
Yeah, I'm coming. I would really like to thank our dear coordinator, Dr. Rajshri, who've been with us throughout, our event manager, Mrs. Priya, who has helped us in doing the entire program, and definitely our Shield Pharmaceutical Company with the doctors who are there for his support, as well as our dear Shri,
Chitrakala, ma'am.
Shrikala solita, sorry. Chitrakala,
No
who's the
problem,
backbone,
no
who's
problem.
become backbone of TNFOG. Shield for sponsoring this marathon CME. Thank you all so much. My first thanks would always be to our dear Lord. Without you and your guidance, my dear God, the entire day, our life and our profession, everything lies in your hands. Thank you so much for this wonderful day, the wonderful CME, and the wonderful way you have blessed us today. Thank you all so much.
Thank you, Vijay. Thank you, Nehrika. See you.
Thank
Happy
you.
International
Thank you, Sampath Madam.
Thank
Thank you so much for the opportunity. Thank you. Enjoy.
Thank you, ma'am.
Rajesh.